everyone. Very good morning to everyone. If you could just find your seats, we're going to start. So thank you very much for joining us this morning, bright and early. And we're very glad to really have a collection of experts, both in the healthcare as well as the AI realm, to join us today. So we have an exciting list of speakers as well as breakout group discussions planned for this morning. Okay, so without further ado, I'm going to invite Kedar to give us an opening to set the tone for why we even have this workshop and what are the outcomes that we hope to achieve through this. Okay, Kedar, over to you.
All right, good morning, everyone. I'm really sorry I'm not there in person because of some personal thing. I will be there later, maybe in about half an hour or so. But I really apologize. I wanted to be there in person to kick this off, but from what I hear, it started off really well and smoothly. This is the last workshop for the AI for Science Nobel Turing Initiative. As many of you are probably aware, we've had many thematic workshops over the last month and a half. And we're working towards the 23rd and the 24th of July, when we're going to have this AI for Science and Nobel Turing Initiative conference. And please check out our website, aiforscience.sg. You can find all the details. Your workshop is listed on there too. And later we will actually post the summary and the photos from today's workshop as well. So what's the idea behind AI for Science, right? So we just wanted to clarify this. Probably many of you have heard this. I'll only take about 4 or 5 minutes to explain this to you. But what we are really after in this initiative that NRF is leading is we're looking to see if AI is actually performing scientific discovery, right? So essentially, you can think of this as the Turing test, but at the Nobel quality scientific activity. So this vision was actually pioneered by Professor Hiroaki Kitano, who's also the co-organizer of the Nobel Turing Challenge Initiative. I attended this workshop. They had the fourth workshop happening in February. And essentially, we are working towards thinking that AI has to be the key enabler to actually achieve scientific discovery. So many of you might have a question, and hopefully this will come up during the discussion sections today, during the breakout sessions. We want to define AI for Science very clearly. What we mean by that is that you want to use AI to solve scientific problems towards scientific discoveries, right? And it is separate from the science of AI. And perhaps in this domain, you won't have that problem where there's work that's going on in AI by itself. So one thing I wanted to mention is that we will culminate this particular sort of discussion sessions today and all the take-homes from today's sharing. And we're going to get the team leaders to present on the 7th of June, where they will actually summarize the grand challenges that you've come up with today. And we're going to present this to AI practitioners who are working on foundational AI or research for AI. So we're not looking to see, what new AI technique is being developed today. That's not the goal of the workshop. It's also not AI for X. So please be mindful of this, especially in healthcare. This is true because if you take implementation of AI to solve problems and in applied spaces, that is also not what we're looking for. We're really looking for transformative science, which is enabled through AI and AI only. So if you think about it, AI is the one that's doing the job, hopefully working with the scientists, but you need the data and high performance computing, et cetera, to enable this to happen. So what kind of challenges exist in healthcare? And that's really what we're here to discuss today as a community. So, of course, the end of this is going to be a grand challenge. So it's like a proposal. It's called for proposals that's going to go off from NRF. Professor Subodh Maishlikar, who's the Executive Director of Academic Research, is leading this. And hopefully this will happen in about August or September of this year. And there are obviously top-down domains that are of national interest to Singapore, and there are bottom-up domains as well, right? So we've actually had about 3 or 4 workshops on biomedical-related sciences. So very exciting with RNA biology, digital phenotyping, and then now the healthcare one as well. So it's quite nice to see different domains come together and work together to come up with grand challenges. So we are here today. It's not really end of April. It's almost the end of May. So we're a little bit behind. NRF has organized some study trips to various countries to try to understand AI for Science. We're looking at collaborations in different countries. For example, the discussion with Japan is progressing quite nicely. And myself and Professor Zhang Yang from NUS Computer Science, we'll be drafting the full foundation research capability study report. So all of your learnings from today will be summarized into a 3 to 5 page white paper that the team leaders are actually going to collect for us, Rosa and her team. And essentially, this will be a public-facing document. So it's actually going to go off to everybody, to the public agencies, to the scientists, also overseas. And so please do put your heads together to come up with as specific grant challenges and data requirements as possible, right? And this will give you the chance to collaborate and talk to all of your folks in the community, and hopefully some of you will come together to come up with the concept papers for grant challenge to be done later in August and September. So the key here is, of course, to think about the outcomes. So, please, again, check out the website, aiforscience.sg. There's various different workshops on there. And so I'll just end with this couple of slides. So what we're really looking for is transformative ideas that are enabled through AI, right? NRF is really looking for a factor of 10 improvement in something, or an achievement that is not possible otherwise. And understanding the challenges and bottlenecks towards these problems, and defining how Singapore's research community can best address these problems. So what makes us specially placed, right? So one thing that has come up in other workshops, for instance, is that we cannot be going after large data because Singapore doesn't have the compute to do it. So with specific data, or the Asian phenotype, for instance, how can you actually use that to our advantage? So these sort of things do come up, and that's actually a really nice idea to think about. Where do you get the data from? Again, please elaborate very clearly, what data sets are available or need to be curated, as well as the HPC resources. So as quantitative as possible, right? So we're looking for transformative vision, right? And the data that backs it, so that the AI can help you solve these problems. Here's an example of what it looks like. So as I mentioned, foundational research is basically AI tools. So, general purpose AI, emerging AI, foundation models, VAEs are examples of those. And applied research is essentially a particular application. So this is an example in material science, where you can look at some modification. For instance, equivariance symmetries in neural networks can allow you to solve inverse design of materials. That falls under the realm of AI for science, right? And you think about the new data that comes through, you now have a program on AI for science. And that can then be an enabler for applied research, right? And that's essentially the idea behind bringing the team together. So I'll stop with that. I think this is the ideas that you will be discussing. I think Rosa has a very nice format for this. And again, I apologize for not being there in person, but I'll join you guys later today. That I'll stop sharing. Hopefully that was clear in terms of the audio. I'm not sure if you heard me, but yeah, I'm happy to take any questions if you have any, or I'll be there in person a little bit to answer them. Back to you guys.
Thank you, Kedar. Yes, we can hear you quite loud and clear, so it's all good. Any questions for Kedar? Yes.
How is the weather on Mars?
Windy, and I'm eating potatoes. I'll be there in a bit. Breakfast with you guys. Thanks, Marcus.
Okay, so let's move on. So our first speaker in the lineup of 6 different speakers we have is Professor Robert Morris. So Professor Robert Morris is the Chief Technology Strategist at MOH Transformation Office. And at MOHT, Robert anchors the data and technology enablers, and his current focus is the application of computer and information science, including AI, to transform healthcare. So, Robert.
All right. Thanks very much, everyone. Just going to give you a quick run through, but first I want to thank NRF and Rosa for organizing this, A-Star for organizing this. It's actually quite exciting. And we have to constantly remind ourselves that it's about AI for science, AI for research, and not just AI for health, because it's easy to fall back into the track. So what you'll see from me today is a description of some ways of applying AI in health. But as we go through, you'll see hints and ideas and fertile soil for doing an acceleration of the process, right? Through various methods like transfer learning. But we won't spell that out because a lot of that is actually work to be done. And so I challenge all of us to think in those terms. So first of all, in MOHT, our goal is transformation of care models. So it's not just figuring out new techniques. It actually has to go into a care model, and it has to change patient outcomes. Otherwise, we fail if we haven't done that. So the way we think about it, this is, unfortunately, it's not very clear, the screen, but the way we think about it is there's three essential parts to this transformation. One is the sensing of the patient, and that could be through a device, that could be through, like a wrist device, a ring device, a blood pressure machine, blood sugar machine, etc. It could also just be through active sensing, where the patient is answering questions or telling your problems. It doesn't have to be a device. And then that goes into, typically, but not always, goes into your smartphone. And the smartphone can provide some care at the edge, some immediate care, which is very privacy preserving if it's done at the edge. But also in many cases, signals will be sent up to the cloud, and more advanced techniques, learning techniques, etc., can be applied in order to send exercises or hints or coaching prompts or nudges to the patient to take their medication or to exercise or to help them with smoking or to help them with recovery of some kind, or just saying it could be just wellness as well. And then a critical part is that for many patients, particularly those that have been discharged from hospital and people that are under care, it may go to a care team as well. So that care team, and those care team, those care coordinators, nurses, etc., are often very overloaded. They have caseloads of 100, 200, 500 patients. They cannot keep up. And so the whole point of this system is to allow them to concentrate on those that need their help today at this moment. And we're practicing that. We've been practicing that for several years. And turns out you can do it. So when I say sensing, intervention, and AI is critical. And AI will be critical to get the AI and science speed up we're talking about. So we're applying this principle today across the whole life course. We actually haven't done maternal yet. We're looking at that, but we're doing it for mental wellness, resilience, etc., throughout the life. So we have over 1 million people have come to mindline.sg, which is our tool. About 20% of our population has touched this tool, mindline.sg, for mental wellness, and it has AI bots built in, which give you coaching and take you through cognitive behavioral therapy, exercises, etc. Some of them are third party that we've integrated in. We have a serious mental illness project, which I'm going to show you. This is for people, the couple of % of the population that has serious mental illness that have been discharged from hospital, and we're monitoring to try to help them not to be readmitted and to help them to manage their illness. That's called HOPES, and that's been in service out of IMH since last July. We're doing it for diabetes, hypertension, not yet lipidemia, and not yet asthma, but we're working on these two. So diabetes and hypertension through a project called PTEC, which is in every polyclinic in Singapore now. So you can sign up for that in every polyclinic. And we're hoping to get it to the GPs as well. It uses very basic AI. It uses rule-based systems in order to give coaching prompts and reminders. And then we have a post-discharge program for post-heart attack called AMI Hope, which uses coaching, and I'll show you how that's done. And the whole idea of this is that this kind of collects data, uses data, and this all flows into foundation models. And we do it on any platform. We're using all of these platforms to do it. Actually, not quite yet. We're mostly HD Plus and Hopes today, but we're working on integration into Epic and Health for those. So a few examples of why it works. So this is the Hopes program that I mentioned to you, which has been deployed since last July. The way it works, it picks up signals from your phone, from your tapping speed, from amount of screen time that you use, your sociability, your location, your activity, etc. It's all picked up from your phone, and also from a wristband, which is particularly useful for sleep. For me, sleep is a very important variable to us. That all goes into AI algorithms, machine learning algorithms, and then it either, and it could be, it's not just these sensing, it's also you're inputting how you feel today, right? And then if you're fearful or you're stressed or whatever, that all feeds into AI algorithms, which then dispatch a AI-based bot. This one's a third-party bot called Wise. It's probably the most successful mental wellness bot in the world. It's out of US and India, which we host on our platform. And then we also dispatch a red, yellow, green ordering to the dashboard for the care coordinator, who then goes and calls and gets in contact with people who seem to be in danger of relapse, or maybe they need their medication renewed. So that's an example how you can use sensing, ecological momentary assessments. You can do ecological momentary interventions through here, which are all automated and provided by AI. And you can also help the care coordinator or the clinician to be in contact. So does it work? It's actually amazed us. There were prior strong hints from the US and Europe that this might work for psychosis, where they got fairly good sensitivity and specificity to predicting relapses, which means you might have to be readmitted or go to the emergency room. And thanks to the machine learning work of Creighton, who's sitting over here on the right, we have now shown that we can achieve from a test set, which took us 4 years to collect with 250 million events on patients, we can achieve about 90% sensitivity and roughly 90% specificity, which should be good enough to prevent intervene in most relapses. The variables are interesting, things like your tapping speed. This is a cognitive factor. When you're not doing well, when you're having a cognitive impairment, you will tap slower. This is well known, particularly for depression. And then other things like the amount of time are you holding up at home? Are you going out? Are how's your sleep efficiency? Is your sleep starting to get disturbed, etc.? All of these are very, very valuable for mental wellness. So that's one example. I'm only going to throw you 3 examples. The second one is about post-discharge, and this is post-discharge from heart attack. And it's really important that a heart attack patient uses that event as a way of changing their lives. They've had a heart attack for a reason. That might be diabetes or smoking or high blood pressure. They had it for a reason, and they have to change their life. And so the crux there is the change that they make. And they receive coaching from a clinician who in this case is a pharmacist, because the initial recovery from a heart attack is about medication regime to help with the correct remodeling of your heart tissue as it remodels after you have the heart attack. So that's very important that be managed. Also an AI engine, and the whole idea is it's a patient mindset. Anything about changing your life requires you to have a mind-body connection between your physiology and realizing that you're going to die if you don't do something about this, okay? And your mind, your willingness to take action, which could be related to taking medication, it could be related to activity, diet, alcohol, tobacco, those kinds of things, stress levels. And so we provide that coaching today largely through the clinician, but we're starting to provide, we've just begun providing through AI engine, where we watch the physiology, taking measurements, taking inputs, taking active inputs, and feeding back hints. So we'll be coaching again from the clinician and the AI engine. But this is very much more psychologically and motivationally based. So we use Prochaska's theory of change. We try to detect what state of change the patient is in, only give them things that are appropriate for that. But we're observing a lot of data in both of these projects, and that creates the opportunity for AI in science. And in fact, on the first one that I just mentioned, we're currently now trying to do a transfer process from psychosis to depression and mood disorders. And we're not going to run another 4-year clinical trial. We can't afford to do that. However, many of the symptoms are very closely related between these. Many of them have a cognitive basis. So we're trying to identify those through past data and ongoing data, and then do this transfer learning, which means instead of 4 years to do the next one, maybe we can do it in 6 months. You can bootstrap. So that's a principle that I think you might come back to today. And the third one is Gen AI. We've just started working on this the last few months. As part of Mindline, which I mentioned, we have 1 million people that have come by. We recently started a peer support group for youth, which is, you can think of it as a Reddit, but it's safe. So it doesn't have junk or toxicity on it. It's moderated and it has professional counselors and clinicians, clinical psychologists monitoring it and answering questions and making sure that poor advice is not given. 100,000 people have been by that site so far in Singapore, all youth, with mostly youth, we think. And about 10,000 have posted on it and put their problems on or try to help others. But this is quite interesting because, again, we have a small number of clinical psychologists who cannot handle all of Singapore. They cannot manage this. So we're using Gen AI not to advise the patient. We believe that's too dangerous at this stage because of hallucination. We have suicidal patients, etc. Right? There are people who come on and say they want to end it all. So we have to manage those. We advise the clinician who has having trouble keeping up with all the load on a Friday night or whatever. So we come up with materials for them that they can cut and paste into the client. It's a bit hard to read here, but this is somebody who's not sleeping, who's having great difficulty sleeping, is also pregnant and quite worried about what this stress might have, the effect might be having on the baby. So the AI, which we've trained with prompt training, and also the 500 odd resources that we have in MindLine, we use those through RAG, through retrieval augmented generation, to generate responses and also resources. And if the psychologist likes them, they cut and paste them into the window. That's where they've come up and they've been pasted. They're very good. They're coming out very, very well. And in some cases better than wiser, but there's still a safety factor. So that as a principle, we're not giving this to the patient yet. I don't know if we ever will. So I just wanted to wrap, that's the third one, that's working. Because it's not direct to patient, we can use it as an advisory tool to clinical psychologists. Oops. Okay. Let me just end on foundation models, because it's something I think you'll be talking about today. So foundation models are very exciting for health. We need to think about them in the full context of all the information that we gather from patients. And I mentioned we have 250 million events, we have SG 100K, we have Gusto, etc. So we have a lot of actually quite good data in Singapore. We also have massive data sets abroad that so far we don't have access to, but we want to get access to, like, for example, Epic Cosmos, which is 246 million lives with complete records for 15 years. We can learn from that, learn a tremendous amount about risk from those time series. So both Singapore and North America. So that's time series data. There's also all the knowledge. Okay, so there's huge, wonderful repositories, like 35 million published medical papers that we want to mine. Remember, about half of them are outdated or wrong. So we need to be able to mine them in a context so we only get the correct or the current information. Fortunately, several companies are doing that. Elsevier is doing it through a tool called Clinical Key AI, which is a very advanced tool, which summarizes the literature and answers questions for you. If you haven't seen it, it's knock your socks off in terms of what it can do. It's very, very recent. It's only been out of, it's not even out yet, but you can get see betas of it. There's also UpToDate from Walter's Claws, and there's others that are starting to use Gen AI to summarize all the knowledge. So in a foundation model, what you typically do, you just throw all this data in a bucket, a purist foundation model approach. We just throw it all in a bucket and you try to learn the response to certain conditions. We think that's not going to work in the near term. And the reason it's not going to work is, part of the problem is we can't get access to all the raw data. We cannot get the literature unless we're willing to breach the terms of use of the licenses that we have to, like Science Direct, for example. So it's currently being argued out in the courts at the moment, whether that's fair use or not to mine all of that data. We're not sure how that's going to come out. But what we have is a temporary approach, which I'll just show to you, interim approach, which we think was going to work very well to factor this very large, enormous space. And it's the following, is to take all the information that you get through time series, customized for Singapore, because we know things are different with the Singapore phenotype, and estimate risk. So we know, and I won't show you the slides on this, but we know for this Chinese 54-year-old lady that she's at most risk for CKD and IHD, for kidney and ischemic heart disease. And then we can use the knowledge model to say what to do about it. Okay, so that's a very simple factorization that we're experimenting with, which prevents us from having to do a mining, which would probably cost $1 billion for us to mine anyway. So it's both a question of access to data and the huge costs of doing ab initio online. So by doing these two, there's a chance, and we're actually already able to do this. And there's other approaches that I won't talk about, which use self-discovery, similar to what AlphaGo did to play games against itself. That's a very interesting approach that some of you may be thinking about. The problem is we do not have while we have a base model for chess and Go and for kinetic chemistry and for materials where we have like force field models, etc., and molecular docking models, we don't have that in health. We barely have a model for the cell and for endocrinological processes, and even worse for mental health, we don't have a model for synaptic cleft. We certainly don't have a model that gets you up to behavior. However, we do have a model of one kind, which is the entire internet. The internet is the summary of all human behavior and knowledge and feelings and emotions and positive and negative feelings. Maybe we can mine that. And so we're experimenting with that approach as well. So with that, you've seen some hints in here. I haven't told you how to massively accelerate or improve science, but this is the foundation. And I think I mentioned a few examples as we go along. There are lots of problems that if we don't find a different way, we will not be able to compete internationally. We will not have the billions of dollars that are needed for the mining. We will not have access to all the repositories. We may not have access to Cosmos. We're negotiating that. The clusters here know about what's going on there. We may not have that access. So we have to use other methods. And we have to be very, very focused in how we do it. So we use this wonderful program that A*STAR has to actually accelerate the science, the research, and give us these breakthroughs at a productivity that we haven't seen before. So with that, over to you, Rosa.
Thank you, Robert. Quick question. So maybe I'll just start. So Robert, I think whenever we talk about healthcare transformation, it's this great sense that AI is going to be part of that. But what do you see is, really the biggest challenge towards transforming? I mean, whenever we talk about metamorphosis, there's always some hindrances.
So
It's a huge challenge. And actually, we had a workshop like this a few weeks ago. And since we have about 2/3 of the projects we talked about were mental health, we had the CEO of IMH come. And he used the Cinderella analogy. He said, watch out, the pumpkin. What did he mean by that? He said, it's all wonderful. You get a research grant and a pumpkin, your raw ideas change into this beautiful, bejeweled carriage. Okay, but at the end of the research grant, it turns back into a pumpkin. And you have nothing except some nice publications. So the whole goal in this program, I think, is to keep it focused on changing outcomes. Even though it's a science program, we have to stay linked with our cluster colleagues that are here in the room. We have to deploy it. We actually have to do it with patients, show outcomes. So that's why we constantly say it's not enough. For us, sensing is very profound. AI, I mentioned a minute why AI is essential, but intervention is essential because it's the only way you change outcomes. So if you're purely modeling something or purely picking up some signals, finding some effects and doing some predictions, not good enough. Unless you intervene, unless you have a way of changing when the patient takes their medication or gets them to give up smoking or gets them to lose some weight or whatever it is, right? Unless you intervene, you're not going to make any difference and you're going to have the pumpkin effect, okay, which we don't want. So that's the first thing, and that's the hardest challenge, is actually translating that into, and I know that some of you here researchers, you have very good clinical partnerships. I just encourage you to strengthen those and do this in the context of a clinical trial. Or some form of trial or pilot, and not just do it in the form of research. So that's the first point. And why is AI essential? Because the problem of medicine today is a problem of information. Everyone is in massive overload. The patient's in massive overload, and it's getting worse. Actually, for those of you who, when I was using ChatGPT 4.0 over the weekend, it's just as bad for hallucinations. It's giving nonsense. We see nonsense. It mixes up cancers and it's good, it's very clever, very impressive, but it's 15% of the time it's dangerously wrong and says nonsensical things and still makes up references, it still makes up all kinds of wrong stories. So that's the kind of thing we're going to be facing. So patients subject to that, the clinicians said, we think 70% of our clinicians in Singapore are using things like ChatGPT. They're subject to that. So we're all in massive information overload. A clinician with 8 minutes is in massive information, can't read all the records, can't look at the images, etc. So if we don't solve that, we will, we don't know what the no-do gap is in Singapore. We know that in the US, we know that about 55% of it from at very detailed studies, about 55% of the correct care is received. That the knowledge, we know from knowledge experiments, that the answer is known about 73% of the time on the average. So that's a 73-54. Other countries it's 70-40. We don't know what it is, but very senior people in Singapore tell me that it's probably not much better. So where does it come from? Information overload, ignorance, lack of knowledge of the patient's condition, lack of ability to execute it. Sometimes the patient was offered, but they don't receive. So that's it. Hard problem. AI is, we won't do it without AI. And we won't do it without the emphasis on intervention, getting the right data, getting current data, an incredible amount of information that's in the literature not being followed. But I can't blame the physician. There are over 1 million papers a year on cancer. What do you expect? So AI is essential, interventions essential, managing information overloads. Those are the barriers.
Okay, thank you, Robert. I think we gotta move on. So our next speaker is Prof. Jonty. He is a member of the Center for Health Innovation Council and also Director of Health and Social Change Academy at CHI. He's also the Clinical Director at the Population Office at National Healthcare Group. So.
Thank you, Rosa Qi. Now, let me get myself. Good morning, everyone. It's lovely to be here. My name is Jonty. I should probably start with one of those caveats. You always talk not to start presentations with caveats. The key caveat here is I'm quite new to Singapore. I've been here about 4 or 5 months. I'm utterly new to AI and I'm pretty new to research. So I've no real idea why I'm here talking to you, but I wanted to use the opportunity to share a little bit about the approach that we're trying to take to population health in national healthcare groups. I work as clinical director for what's called the Population Health Campus in National Healthcare Group. So I wanted to share a little bit about our approach, but also try to, I think, stimulate some thought. Because really the only way in which we are going to understand the opportunity that data and AI offer in terms of delivering improvements for population outcomes is by engaging with colleagues, many of whom are in the room, to help us to understand how we can think through the particular challenges we face in our system with responsibility for our 1.5 million people in North and Central Singapore, and start to think about how we can use data more systematically to address some of those challenges. I should say by trade, I'm a GP as well, so I'm a GP, and so again, don't have huge amounts of technological experience or expertise, but I kind of want to zoom out a little and think about the population, set a bit of context around that, and then think about how we are trying to apply AI or understand or aspire to some of the AI opportunities that there are for our population. So first of all, I think just to probably tell people in the room much that they already know, Singapore, of course, is rightly proud to have some of the longest life expectancies of any country in the world. But importantly, we know that alongside those life expectancies, Singaporeans are living on average about 10 years of their life in ill health. So towards the end of life, people are living in ill health. What is driving that ill health? Again, this won't be a surprise to most people in this room. This is about chronic diseases. It's about long-term conditions, diabetes, hypertension, cardiovascular disease, metabolic conditions, and so on. What is driving those? So, you know, if I had to choose two, smoking and obesity. This is common across the world. I didn't have to learn this when I came to Singapore. This was true in Southeast London where I was working, and as true as it will be anywhere else. So we know that a lot of what is contributing to those 10 years in poor health are opportunities that we can think about in terms of prevention and starting to support people who are unwell in a more integrated way. Importantly, when we think about population health, We shouldn't just think about it as a kind of homogenous mass. We often do when we talk about statistics, average life expectancy. So people in Singapore living up until the age of 85, but that's not true of everyone. And the principle of equity is really critical when you start thinking about population health, because actually health isn't distributed evenly across the population. There are an enormous number of determinants that will drive inequity in a population. Some of those relate to access to health services, but actually the majority relate to wider social and behavioral aspects of people's lives. So the reason I wanted to flag that is that one of the things we then need to think about, if we're going to think about a population, is how do we understand that population in a way that enables us to target parts of the population and reduce some of that disparity that exists. When we're thinking about this in NHG, we take a life course approach to trying to understand some of those opportunities. And I'm not going to talk in detail about our sort of broader strategy, but just to recognize that I think in particular, in the population health campus that I work with, we're trying to think about those opportunities for prevention. And we're trying to think about how we can support people as they become unwell to stay well, how we can support people to be independent as they age within their communities, working with communities of care, and then finally enabling people to receive their care at the end of their life outside of the hospital and to die in the place of their choosing. So we have some key targets as a population health campus. It's not that I always want to share our KPIs out loud, but it's helpful sometimes just to understand what it is that we're trying to focus our attention on. In the space of prevention, people will be aware here through Healthier SG, we're trying to think about how we build stronger relationships through enrollment with our clinicians, with our primary care colleagues. We're trying to think about how we actively encourage people to participate in their healthcare planning, but also in managing their own health and well-being. And we're very focused on those chronic illnesses that I talked about. So we've got some key ambitions around helping people to manage diabetes, hypertension, dyslipidemia. But importantly, of course, if we can prevent those conditions arising in the first place through some of those behavioral changes, smoking, weight gain I've talked about, then that would be key. At the other end of life, we're thinking about how we support people to stay well in their communities, working with communities of care, understanding how we can support people to remain outside of the hospital. The challenges that you will already have recognized, I'm sure, of an aging population and of those additional 10 years of unhealthy life are that they create tremendous pressures on the health system. And it won't, again, surprise you that those pressures of demand are translating into quite an unsustainable financial future. So we have to start to address the ability to help people to stay well. And then finally, to ensure that actually they have the support at home right up until the very end of their lives. So what on earth has AI got to do with any of that? That is one of the things that I've been grappling with a little bit. And one of the things we've been talking a lot about recently, and again, this is not limited to Singapore. This is a conversation that I'm certainly having in the NHS in the UK, is this term population health management. Now, this can be hugely complex. In my mind, as a relatively simple GP, it's not terribly complicated. It's just about starting to use data and insights that we have about our population much more systematically to identify opportunities to intervene or improve the outcomes for those patients. So it is no more complicated than that. Anyone who's worked with any kind of improvement cycle will recognize that I'm basically just trying to anchor population health management in that improvement approach. Let's use data and insights, let's understand the opportunity, and then let's create interventions that can help to support that. A great example of something like this will be vaccination programs, for example. In the UK, and I'm absolutely sure in Singapore, during COVID, we were in almost real time able to identify pockets within our population where there was the greatest level of hesitancy about uptake of the COVID vaccination. We were then able to work with those local communities to understand some of their anxieties and to build interventions that potentially helped to address some of those. That was how we started to increase the uptake of the COVID vaccination. That is population health management in action. It's using data and insights to arrive at interventions that we can use to target those populations who are potentially being disadvantaged by the way we're delivering care currently. So if you try to think, and a lot of this, as I say, is relatively aspirational, but some of this is definitely starting to come to fruition. What are the opportunities for AI, for data-driven insights, for starting to understand the population differently? When we start to think about data within the population, we can start to think about what kind of patterns might emerge, what kind of profiles across the population, how we might be able to predict some of the opportunities to intervene earlier, how we might personalize some of the care in which we want to provide. So this goes all the way across the spectrum from planning and resource allocation and into direct care delivery. But we have significant challenges around data, and this won't surprise any of you. We have data that is not connected and comprehensive at the moment, so we don't connect health and social care data very well. Our data is principally for patients, not the population and our residents. Due to often quite complex governance processes, a lot of our data is in silos around particular institutions. And of course, I've already talked about equity. So what we have to be very cautious about is using data on a population that is potentially already has inbuilt biases that we need to consider when we're starting to use some of this. I just want to talk about very briefly the three things that we are doing. I'm not going to go into lots of detail. We are trying to develop and link a population health data mart. So we're trying to ingest data from across a range of different sources, and we're going to migrate that into the National Helix platform and start building a resident database, connecting our patient level data with our resident data, start to try to build a more comprehensive data set that we hope will start to enable us to derive better insights than we do currently. But it won't surprise anyone here who's worked with data that really data and data quality and our data strategy is our AI strategy. So we have to be very clear that without this, from a population health perspective, we are going to make very little progress. We recognize that if we can establish that population health data mart, that will allow us to start to link some of those wider risks that we talked about, those wider social determinants, and we can start to think then about how we build a better profile of our population and how we might then intervene differently going forward. We're also establishing something that we have called HEAL. This is kind of hot off the press, I guess, because this is very, very new to NHG currently. So this is our Health Empowered by AI Launchpad, located in the Centre for Healthcare Innovation. This is very much about recognizing that data isn't everything. But undoubtedly, we need to make some progress around our data infrastructure. But we then need to think about how we create an environment in which people can access that data, start to develop new models, address new problems, but importantly also have the necessary training and support to start to deploy and adopt and scale that. Because if there's one huge challenge, it's going to be about actually how we scale this into our working practices in an ongoing way. By working with the Centre for Healthcare Innovation, people already have skills in thinking about adoption and scale. And we hope that we will be able to create an environment in which people can start to, working with our data scientists, can start to think about building new models, but then equally, and as importantly, think about deploying those into clinical practice. And we've benefited significantly in our thinking by looking at some of the work that's been happening at NUHS on this, and we'll be using their Endeavour AI platform as a start point for us in this work. I won't talk through the various different offers that we are building within HEAL, but this is very much intended for our frontline clinicians and care professionals to be able to interact with the data and to start generating new models to start to address some of the challenges that they face on the shop floor, so to speak. So finally, beyond data, beyond developing capabilities, we also need to think about how we're going to partner differently going forward. And one of the things I wanted to be very clear about is, again, one of the reasons that it's very helpful to have these conversations is that we will need to partner with people with greater expertise and understanding than us. Technology companies, academia, and I'm very thankful that we've got great colleagues, Dr. Heng leading some of our research work in NHG, who can help us to think about actually how we provide a much more collaborative approach to this going forward. We will equally need to think about working with colleagues, thinking about policy and regulation, because it's clear that we need to try to, so far as we possibly can, enhance access to this data. But we also need to remember that we must at all times think about patients' perspectives in terms of their expectations regarding their use of data. On that, I will thank you all very much indeed. Thank you.
Thanks, Dr. Qi. Any one quick question? So I'm really excited to hear that there's a new effort to provide more data for researchers. I think that a lot of AI scientists in the room would be excited to hear that. Do you have a sense of what are the first kind of data that might become available through this platform?
I was hoping I could no questions, but there we are. So obviously, the platform is already in place, and the first data that is available is patient-level data. So we've got the data that reflects obviously what we have already in our EMR system. So there is data already available. I think what we would then like to be able to do is to start to link up what we have in terms of what's our CRM platform. So the data that we have about our residents that we get from MOH. At the moment, we need to essentially establish a resident key that would allow us to link data that we have on our residents with our patients. That for me is my absolute first aspiration, because we have quite a lot of information about our residents, some of which they contribute themselves and increasingly are going to be doing through some of the applications that we're developing at NHG. But if I can start to link that, then I've started to get a genuine view of the population that we serve in North and Central Singapore. So that's the first step. There will be a huge variety of other data sets that we can start to include. And from my point of view, screening becomes critical to all of this, because we know there are phenomenal opportunities again. And we have significant disparity if you look across our population in terms of uptake of screening. So it's a lot of, well, from my point of view, a relatively well-known data sets, but they're just not connected at the moment.
Okay, thank you. All right, next we have Dr. Daniel Ting, Director for the Sing Health AI Office, also the SNEC Chief Data and Digital Officer, as well as the Head of AI and Digital Innovation in Singapore Eye Research Institute. So welcome, Dr. Daniel.
Yeah, thanks for the kind invitation. Yeah, thanks everyone. I actually given one the presentation before for NRF, and so I'm gonna actually just focus more on the responsible the AI governance framework, and of course where do we go next. So I think this is one of the things that we know have actually passed, but actually it has catalyzed the whole field how we should actually be using AI and digital technology. So I mean, I know we're talking about generative AI and stuff, but we do actually need to know where the data is coming from. So I think we are currently dealing with like trillions and trillions and trillions of the data points that we actually need to know how to handle them back end. Because if you don't actually know how to organize your data, whatever you actually pump into your large language model is all going to be rubbish. So I think this is one of the key the slides that I wanted to actually just highlight to everyone here. And of course, this is the interest pre-Gen AI. Of course, after Gen AI is actually increased by 10 to 20 times. We all know that. So if you're actually gonna make a very holistic large language models, I mean, Robert actually showed a very nice, the flow chart just now, how the large language models, the foundation model should be done. I totally agree with what Rob has just said. I mean, the current large language model cannot take the healthcare specific use case. And how do we then actually gonna handle all the triaging, the analysis, the diagnosis, the surveillance? How do you actually close the loop? This is what we actually have to think about. If you look at just the horizon scanning, what is the trend right now as we speak? AI is an extremely wide field, right? I mean, we're not here talking about ChatGPT. We're talking about how do we build an AI algorithm so that I can use it for my patient the next day in my clinic. So, I mean, this is a simple questions that would actually entail probably hundreds or 1,000 steps before this AI algorithm can be actually used for the patient, right? Safely and in an ethical manner. So if you look at what the field has actually gone from, we've gone from machine learning, right? So we use the data, we will use like random forest and XGBoost, and a lot of the traditional machine learning is, well, I mean, it's not sexy anymore because that's a pre-deep learning. Is it still of use? Yes. there's a lot of use. So I mean, this is one of the things that I also wanted to highlight. A lot of the ICU patients that are currently still using a very traditional machine learning and still giving them a very good performance. So I mean, this is actually on a real-time clinical use as we speak. And of course, the image-based deep learning, right? So basically, pixel-based deep learning system, right? AlexNet came out, it absolutely changed the field. AlexNet to VGGNet, and of course now to Vision Transformer. So I actually went through a 10 years evolutions of the pixel-based CNN as we actually spoke. And of course, this is a monster, right? When it first came out, 6 months, there's a two school of thought: stop it for 6 months or do it as we actually govern the safety. So, right, I mean, there's two divides of thoughts when it actually came out. So of course, this is just one to highlight between the current AI engine versus the one in the past. The social media popularity, this is one of the most popular AI engine that we are actually dealing with. This is just a very snapshot, and I must say that this is actually put out just 4 months ago. Every single day, there's people like competing, you know, in the hugging phase, claiming that they are, you know, bragging, like, you know, they're actually competing for the 0.01% decimal points like performance. Is it useful? I mean, so this constantly I ask my team, don't actually get distracted with the performance, like, you know, hugging face, like the performance chart, because this is not what we need in healthcare. You actually need a very safe and very reliable system, and not like the best system, right? So I mean, this is one of the paper that we published, you know, probably one of the first review article in the field in Nature Medicine. And we actually highlighted 5 big categories. When it first came out, we thought the first one, it could be organizing summarization. So I can tell you 9 out of 10 things, if you go to any parts of the AI conference in the world for health, this is what people actually have already, you know, is rigorously doing it, because the value add to the healthcare system in order to reduce the physician's burden, burnout, this is the key. How do we make life simple for us or the houseman, right? As I'm currently a senior consultant, I don't actually get burdened too much with this. But can you imagine a HO, a houseman has to summarize a long stay ICU patient with multiple, you know, admission, discharging within the same hospital stay for 2 months, and then this person is going home tomorrow, right? You only have like, and plus your list has like about 20 patients, right? So I mean, those are the things that, how do you actually leverage on all this technology to help us to live better, to give us convenience? I think that's a key thing that I think we need to think about. And of course, patient education, I had a later avatar, but I'm not sure it's going to work. So, I mean, this is some of the deep fake technology that if you put in a good use, that is of high value, I mean, to what we do. But if you actually put it wrong, I'm not sure how many of you have actually, you know, heard recently that people deep faking the whole conference meeting to unlock the funding from the bank. This is a huge cybersecurity issues right now the world is currently facing in the digital era. So how do we actually put all these safety guardrails, you know, to prevent jailbreaks and many others like zero attack for the Gen AI engines? This is something, a key issues to actually think about when we actually move forward, you know, in the next, you know, 12 to 24 months time. And of course, translation, right? I'm just going to play the translation. Not sure whether there's sound, but you want to definitely hear your own. No one. That's how diverse the Singaporean population is. Right. So this Japanese actually shows that, you know, I just have to type, please, no, actually one word, Japanese, please, right? This is direct translation from English to Japanese within just 2 seconds. So this is how fast right now we know the large language model engine can do the translation very well. Okay, I'm not going to play mine. You guys can come and look for mine later. So I just wanted to highlight, now, if you want to do large language model, you cannot run away from these slides, okay? B200, you haven't got access yet. H100, some country has, some institution have a little here and there, but not many. Most institutions have A100, A, but if not, A140K, okay? I mean, so this is the most popular, the chips that everyone sitting here who does Gen AI, deep learning, image-based, you guys have that, right? And then, of course, I mean, the lower one, of course, the desktop-based, you do a smaller scales research. So I would strongly encourage, in order to save the earth from burning down, I'm not sure how many of you have actually experienced a heat wave, turbulence, like 2 airlines are really suffering that. We can foresee more coming. This is not a joke because this is the climate change, the sea level rise that we are currently facing. If you burn the GPU with B200, with not well thought research ideas, and you start pumping in your data, the earth is burning down. This is serious issues. So, I mean, worldwide, there's already a group of researchers looking at how do we actually make it greener, right, in the Gen AI era. And of course, if you can use prompt, please use it because the compute power is the least. Make sure you can actually ask the right question. No different from how the doctors ask the right question to the patients. Ask the right question so that you can get the right information from, from the patient. And of course, RAG, right? Robert talked about RAG, retrieval augmented generation. There's also a very good way, but again, you increases the inference time after that. Fine tuning, again, take another level. And when people want to talk about foundation model, I heard so many about, I want to build a foundation model. Okay, I see it, right. Show me the delta, right? If you cannot share the delta, I saw the 2 minutes, yeah. If you can actually share the delta and you can actually make it work, yes, please build a foundation model that is personalized to your local needs, right? Because US is not going to build one for Singapore use, and the fintech people, the scientists is not going to build it for the healthcare use. So healthcare people have to build one if you think the current technology using fine-tuning, RAG, and prompt are not sufficient. So this is just a snapshot. It's continuously coming out. Top 3, we have Llama 3, we have Gemini, 1.5 for medicine. You have Gemini combined with the Met LLM right now. So all these are the 1 trillion type parameters that we're talking about, right? So Llama except for Llama. And now, if you were to combine the text and the image, this is what you use, vision language model. So when you want to use to build a right use case, don't use a wrong large language model trying to answer the right the research question that you're trying to answer. If you were to actually build something like radiology report with the scan, use a vision language model. Don't use the large language models and tell me that, oh yeah, I want to use the Llama to actually build a radiological report with the imaging. That's a wrong approach. So make sure the right task for the right use. And of course, now we talk about Sora, we talk about AI to video and things. So this is another multi-modal AI stuff that we're looking at. Now, data, right? Without data, you can't build. Without data, I mean, if you can't share data, Singapore is small. How do we actually collaborate with the international players to do it? Federated learning will be a key, right? And now, of course, the back end, cybersecurity. Time's up. So I have still a few more slides, but I'm just going to stop here. Because I mean, the cybersecurity-wise, this is the right place for me to stop. Because the jailbreaking, guardrailing, and all these cybersecurity measures, I think we need a very hardcore research coming out from Singapore. Because if not, this is actually going to be quite dangerous. So with this, I would like to thank the organizer for the kind invite to share. Thanks.
Okay, thanks, Prof. Daniel. Questions from the room, please.
Sorry, my talk's too scary. Yeah, sure.
I'm a research engineer from AUS ECE. So I have a question regarding this, how we can use, that means that the data in medical science are like image, they are different from the optical image. And nowadays, the large language model and also any neural network are very powerful in dealing with computer vision images. However, the images generated in medicine are not the same physical principle as computer vision images. That means our physical law has been used to generate those medical images. So my question is how we can combine or more profitably use physical law to combine with machine learning. Thank you.
Yeah, so I think that's a good question. So, I mean, I imagine your computer vision, you mean the ImageNet, right?
the computer vision stuff, and then with the healthcare. So I think like previously when we started, I see Mengling here, and I started my career with Mengling in the pixel-based CNN at the time. At the time, the only thing that we have is ImageNet, right? So AlexNet and BGGNet. So at that time, actually in the very start of the career, we were actually testing a pre-trained versus untrained. And what our lab found is that if you actually have enough data sets, actually the pre-trained and untrained doesn't actually make a difference. So of course, a lot of the off-the-shelf right now is all pre-trained, right, with ImageNet classification. So my colleague in UK, in London, in collaboration with DeepMind. So I'm not sure how many of you actually see the Nature paper looking at retina imaging-based foundation model. They actually show that if you actually have that, the amount of data set that you need to train a good model is much less. So that alone, and it's a very natural, fit, because if instead of using the cat, dogs and the cars and things to pre-train a model, why don't we use a domain-specific imaging to pre-train a model to actually lower down the bar, lower down the numbers of data sets that you need, and then to actually use a similar model. So this is one of the in my mind, revolutionary, the findings that actually can help a lot of the countries or like the institution where they don't actually have many data sets to actually train a good model. So I think this is one of the things that is currently moving, and I'm yet to see a lot more research coming up from this field. Yeah.
Okay, thanks, Daniel. Next, we have Dr. Ian Mathews. He is an emergency medicine physician with NUHS, and he's also the Deputy Group Technology Officer in the hospital group, focusing on big data in healthcare and AI for clinical innovations. So, thanks.
Thank you. Thank you very much. Also, not to start with caveats, but I'm going to start with caveat anyway. I've been in Singapore for a long time, but I'm nowhere near an expert as the previous three speakers in AI. In fact, I think Rosa misunderstood. I told them my intelligence was artificial. So I'm predominantly an emergency medicine physician by training. That's the only training I received. The rest is just artificial. I also work with Prof. Ngiam in the Group Chief Technology Office, looking predominantly at data infrastructure and AI tools. Now, our speakers have spoken on quite a range of topics as well. I'm going to follow through on what they've spoken on. This was completely unplanned, but we did a great job, I think. I won't go too much into this because I think Jonty has touched a little bit on this already. We know that Singapore, we have an aging population, and we're not aging as gracefully as many people would like. Like, actually, I'm 23 years old, but people think I'm a lot older than that. And yes, changing demographics. In NUHS itself, we have a model of our digital health plan, which includes trying to provide tools not just to our clinicians and our physicians and our healthcare staff, but to patients as well. And we have a variety of those. But why did we need a solution to begin with? Now, as has been mentioned before as well, data often belongs in silos. These sorts of silos do not often communicate very well with each other, number one. We have an aging population, which leads to longer lifespans. Singapore is experiencing a decreased birth rate. I'm trying my best, but I need help with that. We also have an aging workforce. So in the next 10 years, we're going to see a drastic drop in the ability to care for our patients in the same way with the same workforce. Healthcare costs are rising. We are using health services more as a population, becoming more aware of illnesses and approaching, looking for health solutions more. And there's also a great push towards technology now. Now, that is why we created the Discovery AI platform to start with. I'll speak very briefly on the Discovery AI platform and the Endeavour AI platform, which was Jonty had mentioned as well earlier on. Why is there a need for change? If you liken healthcare's sort of revolutions to the various revolutions as well. At the start, the industrial phase, we had a lot of mechanization, water, and steam power. That was like our first phase in healthcare for data. There was paper records, which was very knowledge intensive. As time has progressed and as computers and automation came into the world, we started looking at analyzed insights for our data after we've gone through the electronic medical record phase. And this is very experience intensive. The very next phase is cyber or physical systems, where we are looking at automation, especially of our physical systems as well. Things like cloud robotics, greater AI tools. I'm not sure if any of you have watched this show. Has anybody watched this show? Oh, a couple of people have watched it. Great. This is the first time I've seen more than one hand go up to the show. Usually it's my own hand. Again, my intelligence is based on TV. So this program is on iTunes. I would highly recommend it because it's a great drama. But it is, without giving away any spoilers, it is about a group of people living in a silo. What they don't realize is that this is after some major catastrophic end of world event. What they don't realize is that there are multiple other silos. And each silo has a different language. They don't know the other silos exist. And there is very little communication. Sound familiar? That's very much like data in our institutions, all belonging to silos. So we may have a silo for our demographic data. We may have a silo for our radiology data. Our lab data belongs to a different silo. So this is the importance of architecture and how we need time to develop something proper. And that's what we tried to do in NUHS, which was bring everything to a single silo. A single platform, recoded to a single code so that it could all communicate with each other. We knew where the data belonged. Each of the previous silos, data owners now belongs to a single central data silo. And that was our Discovery AI platform. It looks very complicated, which I like because it presses people without anybody knowing actually what it means. I hardly know what it means. But essentially, we have multiple data layers, access to data points, which we have put in from our tissue repository, various databases, etc. We train our AI models on this platform. So basically, this platform is where we have stored all our data, and we train our AI models on this platform, Discovery AI platform. As a next step, that wasn't enough for us because that took up a lot of our computing power and a lot of space. We developed the next platform, which we called Endeavor AI. Now, this is where it gets a little bit more exciting. This is where we plonk all our AI tools. 90 to 95% of our tools that we have in NUHS are built in-house. So we put all our AI tools on this single layer, and it draws data. It trains on Discovery AI. It draws live data from wherever, whether it's your electronic health record system, whether it is a healthcare commercial cloud or whatever it is. We can provide a channel to that. It draws live data out, runs it through the algorithm, and pushes the output back. So that is the TLDR version, because of course these conversations, we had to talk about this yesterday for our senior management, and that was a 4-hour conversation based on this architecture. So what our aim is with Endeavor AI is that we're looking for stream capable for the whole of the cluster in NUHS. What does that mean? Stream capable from Epic, our current electronic health record provider, which is the next phase of Singapore's electronic health record. Everybody in the public sector seems to be now moving towards Epic as our one electronic health record. Stream capable meaning as Epic is running with various triggers, the tools can be auto-generated and outputs pushed back. Right now, it's cut and paste. I'll give you a quick example later on, but the aim is stream capability, and we are approaching that. So what about our vision of AI in healthcare? Our vision of AI in healthcare has never been for AI to replace clinicians, to replace our staff. It is to augment and to make our work easier so that we can care for our patients a lot better. And part of that and part of our solutioning is we recently set up an NUH Cambridge Office of Innovation specific to NUH, but the aims are 3 main aims. Education, where we upskill all our staff in some form of innovation. This is pretty much digital innovation. We hope to leverage Epic and Endeavor AI to promote the use of clinical AI tools and productionize them, and to build an active hub for innovation. Now let's move to a bit of the juicy part, right? The actual clinical users that we have. Now, I'll talk a little bit on imaging, but the rest of it will be other kinds of models. This is one of the models that we did not build in-house, partly because there are many solutions already on the market. So we are working with a vendor for this. So this falls into that one of the 5% category. We plan to go live by March 2025. The biggest challenge and the biggest time concern for this is not the technical aspect of it, it is the procurement cycle of it with administration. But basically, what it is now, current use case. If you come to the ER, my department, and you see one of my medical officers and you need a chest x-ray for whatever reason, whether you're minor illness all the way to severe illness, before the medical officer sends you home, he waits for the x-ray report. This has been a creeping change in practice. In the past, the medical officer will look at the x-ray itself before waiting for the report, make a decision, and send the patient home. X-ray is normal, send the patient home. But there have been many times, and especially with COVID, where there was a little bit of over-reporting in COVID as well, for good reason. People were afraid. They send somebody home and the report comes out, suspicious minor lesion in wherever, or some changes in the x-ray. So now the medical officers, through creeping change and over long periods of time, wait for the final report before they send the patient. So you come into the ER, you see the doctor for what seems like a minor cough, you get an x-ray done, and then you basically wait for 2 to 4 hours before the report comes out. So working with a private company, we are deploying a solution where the turnaround time for x-ray reports goes down to 0 minutes. The moment the x-ray is done, the report is generated. And why that's beneficial, we can now send our patients home faster. I can decongest my ER. Patient satisfaction goes up as well. And you can better detect things that I've missed previously. Now, we talked a lot about generative AI, and let's show you a few examples because I've got not much time left, so I'll go very quickly. We have a bot in NUHS called Russell GPT. Why it's Russell? It's because it's named after Bertrand Russell, the guy who came up with the Prof. Ngiam is a very creative man. But we have many applications for it. Right now in NUHS, we have about 50 applications, 50 teams working on various LLM projects. About 20 are what we are supporting and developing. The other 30 are from the rest of the greater community. But our Russell GPT is basically, as what Daniel had mentioned earlier on, a summarizing tool for one. It's accessible to anybody who's using our healthcare system. Basically, if I'm having a patient encounter, I'm typing in the patient notes, my senior tells me, send a blue letter referral, a blue letter is a referral, send a referral to cardiology. I can cut and paste the entire patient consult note into my Russell GPT and say, please send a blue letter to cardiology. And it will generate a blue letter to cardiology for you. It can also summarize medical text. So in the past, house officers, the junior level doctors spend hours trying to do case summaries. ChatGPT can do this now in seconds, or Russell, our version, can do it in seconds. So that's Gen AI for clinical use. We also are using Gen AI for improved patient experience. We have a speech-to-text tool called MediVoice, which sits in and listens in on a patient's consult with the doctor, which allows the doctor to spend the time looking at the patient. How many of you have gone to a GP or a doctor or a polyclinic or an outpatient clinic where the doctor is just typing on his notes while asking you questions, not even looking at you once? Very common, especially in Singapore, when we have to churn out very fast. So our tool allows for speech-to-text, but speech-to-text has been there for a while. So we have speech-to-text, and the next tool that we employ after that has been converted to text is our LLM tool basically generates an output how we want it, whether we want it in the SOAP format, which is a format that we type in, and analyzed output for our clinical notes. Again, it allows us to spend time talking to the patient. We have the same bot, similar to Russell GPT, but for operational use as well, where staff can use it to write minutes of a meeting. They can use it for CV vetting as well, very existing policies like our finance, HR policies, etc. And I won't go too much into this because time is up, but very, very quickly, we have a tool that we're using LLM for, which looks at duplicate orders. Duplicate orders in CT is a big, big problem because if a duplicate order is actually done, a patient is getting 2 CTs when they only require 1. Why? Because somebody has ordered somewhere along the line an extra CT. So as a result, that requires 4.5 hours of manpower time every day for the radiographer and the radiologist to look through all the duplicate all the schedule for the day to see if there's a duplicate and whether it is a warranted duplicate, that means needed a second scan, or whether it was an unwarranted duplicate. So we put in a tool that basically deployed on our Endeavor AI platform, which basically cut down that significantly. So the usual 240 minutes a day that was required by our radiographer and a radiologist has now been cut down to 30 minutes a day. That's essentially 800% productivity gain. So in summary, the challenges that we've talked about, we solved them with our Endeavor AI platform and also with development of our Cambridge Office of Innovation, where we are leveraging AI tools and upskilling our staff. In conclusion, very lastly, the strategic architecture is crucial. We took 5 years to develop our Discovery AI platform and another 2 years to build the Endeavor AI platform. And that is paying off in its benefits now because all of our tools are being deployed on those. Happy to address any questions. I'm happy if I don't address any questions. The other tools we won't go through. If anybody wants to know, I'm happy to chat with you guys more later on.
Okay, thank you, Dr. Ian. Shall we have at least one question?
Yeah, this is Wing from this. We are actually trying to using Discovery AI for our project. We're working with SNEC. What's your opinion? We can break the cycle more efficiently. Now we're actually facing quite a lot of challenges. We'll be trying to using Discovery AI. Yeah, that's hopefully you can have some insight.
Very dangerous and loaded question. But it depends on the challenges and what they are. I'm happy to chat with you more. But I think data access is always a challenge because ours is an on-prem solutions and data doesn't leave because of patient confidentiality, obviously. Patient doesn't leave. We can try to anonymize the data for you, but it is still on-prem. So we can give you a virtual machine and you can run it off the virtual machine, etc. It will really depend on what the challenge is. And again, happy to chat more during the breaks to find out more about that. In final conclusion, that you know the tribit that I showed earlier on, where we had Discovery AI and Endeavor AI, the top platform is where that challenge can be circumvented. Once we have established channels to our healthcare commercial cloud, external parties outside of NUHS can then communicate and link with us as well.
Okay, thank you, Dr. Ian.
Thank you very much.
Okay, next, we have Dr. Stephen Wong. He is the chairman division for the division of hyperacute care. His expertise is in spinal, musculoskeletal, and sports radiology. And he's in charge of the radiology informatics for Sengkang General Hospital.
Do I use this or do I use this? Right, thank you very much. Okay, so my division just looks after radiology, ICU, emergency medicine, and anesthesiology in Sengkang. But I was previously a radiologist, also an all-grow head of department at Sengkang, the small little hospital at the northeast of Singapore. Right. These are my disclosures. Okay, so I'm the boots on the ground, right? And I face challenges every day. But I was asked to talk about radiology AI challenges, and one of the things is that promise is not the same as reality. Reality sucks, actually, right? How do you ensure explainable, trustworthy AI is a question that we are worried about on the ground. If you look at an AI, radiology AI field now, there is industry-wide consolidation. Companies are taking over companies or merging. Image biopsy and Gleamer have announced collaborations and stuff. I think Gleamer is going to be taken over by image biopsy in the next few months. And thankfully, the traditional players have woken up. People like Siemens, Philips, GEs and stuff have realized that they were falling behind, but now they're fast catching up. And now they're embedding AI into their platforms and their OS, and it helps a lot, even at the machine side, not just on the radiology side. So we're going to see a battle between the vendor-based platforms and the radiology and the third-party platforms. For me in Singapore, being the guy on the ground and not at the top level, okay, control from up down is stifling. Is affecting innovation too, and deployment of any AI. We can test and run it, but we can't use it. Right, funding is an issue. This is issue worldwide. whether for us to acquire the AI products and stuff without senior management approval is almost impossible. And in Singapore, there's very little coordination or collaboration between industry clusters because everybody has their own castles. All right, so any case of their endeavors in discovery, CHI have their own in terms of saying, CNAO have their own. They're not really talking to each other at the moment, but hopefully things will change. And for the radiologists, there's a lot of legacy mindset issues as well. Okay, so this is a diagram drew up by Hugh Harvey many years ago, right? And he sort of opened up the processes that happens when the clinician in clinics on board decide that I want to do a radiology investigation in this patient, right? And from there until when the report finally goes back. So a lot of the current AI are focused on this acquisition, processing, and this 5 areas, right? And all the developments of that, right? Now they're increasingly maybe a bit more work on this area now for dose reduction, image optimization and stuff. Okay, but really, if you look at it, right, these are the things that has very minimal AI or any work done for this at all, right? And these are the ones that actually takes up most of my time, okay? Reporting and reasoning and reporting and stuff and making a diagnosis is easy, all right? That's the work I'm trained for. But increasingly spending more time looking at everything else, whether it's justified, when to schedule it, how to schedule it, when to get it done. And then there are other things that worry me, and which I have no control, and to be wasting my time. Apart from training and teaching, which is supposed to be good, and the odd clinicians coming in and saying, can you have a look at this? All right, okay. So the efforts here are a very small part of what actually happens for the radiology order before it becomes the final report. And there's hardly any work done on this outside. Okay, so and like we say, there's a lot of AI products in the market. There's a lot of them that looks, and this is actually Q4 2023, right? Not even now. For the ones that have Gen AI built in now, or are say to be using Gen AI, this list is totally out of date. So, okay. Right, so there's a caution from a friend, Wujing Kim. He says, you cannot and should not use ChatGPT for medical image analysis. And this is only about 4 or 5 weeks ago, right? Since then, you had the visible language models come out, and this is before the visible language models became a reality, right? And this is something I just pulled out of Imaging Wire, the website last night, looking at this, right? So Wujin has now joined Red AI, which seems to be focused, but they're not looking at AI in terms of diagnosis, but creation of reports, AI assisted, Gen AI assisted image creation, report creation, sorry, and all the other stuff that actually I was talking about, the scheduling and the other things that help patients go through. Right, so, and for me on the ground, I have to decide, where do you put AI, right? If you look at the risk packs, ecosystem PACS network, these are the modality site. This is where the archives are. This is where I sit and client views the internet, and this is where clinicians and stuff. Where do I put it? Okay, do I put it in the modality site, which optimization, stabilization, acquisition time? Do I put it in a reporting site, or do I put it in an archival site? So the architecture at the moment, as most risk packs architecture in the hospital, are not designed for AI, okay? Because most of the risk packs architecture were designed maybe in the 2011s, 2010s, and AI has exploded from 2017, 2018. So we're still trying to figure out where the most optimal space is to put AI in. Okay, so, and for me, the end user, like I said, can I trust AI? And most importantly, do I know when the AI is wrong, right? And for when I issue a report, the final radiology report, do I include the AI generated report?
And if I have 3 or 4 AI modules running at the same time, do I include all 3 or 4 AI generated reports? Do I amalgamate them? And do I need to save them at all? Because this costs me money because I have to build a respect system, a cover system, the cost. And the cost is not cheap. And going to SynCal cluster for money for packs and stuff is not the sexiest thing that SynCal wants to look at. Right. And most importantly, me and Cher, Heng and most radiologists now, we're trained. We know when something is wrong, something looks weird, right? But the next generation of radiologists will have problems, right? Because they will have grown up with AI. They will have grown up working alongside AI. So how do I train them as medical students now and eventually radiology residents to know when the AI they're using is getting it totally wrong, right? I don't have an answer for that. Hopefully you can, right? So at SynCal, we had a test box by one of the third-party vendors. We're playing around with it. Obviously, we can't put it into production. So these are the few sort of lessons we've learned. The training data sets they use for their models is not the same as our validations and testing data sets, right? The machines they use will have different configurations, and that affects the results that we have, right? Diagram tags are not the same. One of the AI models trained, when we had problems, we couldn't validate it. We couldn't even get any results from it. So we actually opened up the diagram tags. And on the outside, the pregnancy field was off. On our side, for some reason, all our patients were pregnant, regardless, right? Male and female, right? And there were some instances, especially for those where you do chest x-rays, extremity x-rays, spinal x-rays and stuff, the matrix size, the pixel size, and the voxel size matters, right? And we were having really a lot of problems. This is one of those where we had a lot of problems trying to even get this to run until we realized that the data sets that they turn on and their image size was smaller than how we generated in Singapore, because they were actually using conventional radiography while we were using digital radiography techniques. So we actually had to write a script to try and blow up their data sets so that we can have comparable results, right? And then the other issue is due to cybersecurity in Singapore, right? We cannot have cloud-based AI access, right? And a lot of these AI modules originally, with the requirement that the analysis is done in the cloud, right, versus the set-top. So we don't know how accurate it is when we're running out of our set-top versus being able to run it through the cloud, and I've not been able to test it out yet. Okay, so the AI bubble, right, or the multiple AI bubbles, to me, in reality, is more wobbling bubble at all at the moment. Okay, so that's all I have to share. Thank you. Oh, by the way, you can invite you all to join me in SIM 2024 at the end of June. Hi, Robert. Yeah.
Thanks, Dr. Wong. Very refreshing talk, and it echoes a lot of things that I'm hearing on the sidelines. First of all, on Gen AI and ChatGPT and LLMs in particular, a lot of people are starting to believe now that it may be a dead end. So Yan McCun at the AAAI conference 2 months ago, he was absolute. Gen AI will fail. It's a dead end. Don't waste your time on it. In terms of he has a Gen AI approach, which is quite different, but the basic process of LLM, the error rates are not manageable within mission critical applications. So like, for example, in telco help desk, yes, it's okay if you don't fix the problem for the telco or the bill's wrong, or you give them wrong info, they'll call back. You know, but this, we're dealing with something completely different. So I think there's a growing, and my old diagrams a year ago had like, oh, you just put this guardrails post-processor on and that filters out most of the bad stuff. And people are now realizing that that's harder than any other problem, and probably insoluble. So I think for delicate problems and important problems, you're absolutely right about LLM. But there's a second point here, which you were also making, which is when all the surveys have been done, when the surveys have been done over the last year, a lot of people in healthcare are saying the most important opportunities are these administrative, supplies and appointments, billing, all of these things are going to be the lowest hanging fruit, and we should all work on those and get those because they're very low risk, they don't risk the patient, etc. But when you look around, no one's working on that. No one's working on it. They're only working on the fancy stuff that in many cases doesn't work or needs completely new. In fact, radiology is probably the best case where it sort of works compared to the other one. So you're already in the, there are viable systems which people are getting good checking out of, for example, right, for chest X-ray out of the other modalities. So do you have any comment on those 2 points? I mean, radiology is the success story in AI and health at this time, and you're posing a lot of questions about it. So what does it take for us to get people to work on some of the more basic stuff to get this to work and to solve the bottlenecks in your job and not the non-bottlenecks? Sorry for the long question.
That's okay. To answer the first question, I think Jen and I and the VLMs at the moment are not ready for anything imaging based, not just radiology, but imaging and things like that. Maybe over the years as you train more, it will help. As it is at the moment, it is for the basic care, patient medications, doing patient brochures and patient brochures. So that's where the best use case and scenarios would be for Gen AI. For the other part of the second question, I think actually the best example of the AI in healthcare is ECG. A lot of them, this is where the AEDs are, and we have an AI algorithm in there for analyzing the rhythm, and it's widespread use, fully accepted, right? And that's actually one of the best examples. The ECG analysis, and that had been built in for years, right? And the other thing is the ICU, the monitoring, patient monitoring system. That had AI algorithm running for years, knowing when the indices are out and parameters are out. Not radiology. Okay. So radiology only came about maybe in the last 10 years or so, right? So we're still learning in terms of image analysis and detection and stuff. Where the value is, I think, is when the major vendors now are realizing it's actually modality side, CT machine, X-ray side, ultrasound side. That's where they're putting the AI into that to cut down scan time, increase image resolution, image optimization and stabilization. And that actually helps reduce our scan time, reduce the radiation doses for patients. And actually, enables you to push more patients with that particular scanner without tiring. That is work that's coming in, and it's actually already having effect on the hospital scan in that workload is gone, or rather quality works, right? With the same number of people that we have. Okay. Where we have enough radiology reports, that's the radiology or not, more cases. For the non-sexy stuff, right? The reporting is sexy, image diagnosis, generation report, this is super sexy, right? Okay. I never realized being a radiologist is sexy, but But the thing that take up most of my job as a HOD is not that, it's actually the protocoling, the vetting of the request factors, ENSA, right? Duplication of requests, radiology requests, and even how to schedule it. Right. If you have say a nuclear medicine patient with a bone scan request, right? The patient actually needs 3 entries within the schedule, right? Arrival, injection, rest time, initial scan, second scan. Right. So actually needs three entries within the schedule time. So there's at the moment previously it was literally just the clouds who were able to train to know intuitively using human intelligence when to schedule the patient, which patient to come back at what time. Right. Trying to write the AI algorithm to sort that out. It's not been that easy. Right. And the major vendors still have issues. I hope they ask some questions. Thank you.
Can I add a point
to
Stephen's response to Robert? I think one of the main issues is really who's sitting in this room today, right? So we have people talking about AI, wanting to develop AI, and we have scientists, we have clinicians, and that's usually the composition of the workshops that I attend. I don't see patient service associates. I don't see radiographers. I don't see the people who are actually doing the stuff that Stephen says is the low-hanging fruit, right? So if we want to create solutions for those, they should be sitting in the room. We should even involve patients to be sitting in this room, to be telling us what they need so that we can devise those solutions for them. So I think one of the reasons why radiology AI is what it is today, most of the development has been done by radiologists with scientists. And that really is in the diagnosis side of things, but less in the work that other people are doing.
Thanks, Yuan and Bharath and Heng for the insightful comments. So as you can see, we intentionally gave time for our domain and healthcare experts to share on some of the challenges that they face and how they think AI could help. But just to bring a slightly different flavor, we have Dr. Alexa come to share with us. She's from SHAPES, NUS, which stands for Science, Health and Policy Relevant Ethics in Singapore. And her interests include AI ethics, research ethics, policy, and stakeholder engagement. So I think it's very relevant to that point. And don't stop yet.
I thank you for the last comment. I think to that point, I'm probably the only philosopher here. So hopefully I can bring you an interesting perspective. Yes, so thank you, Rosa, for the introduction. Yes, my name is Alexa. I'm at the Center for Biomedical Ethics at NUS SHAPES program. I won't go through the acronym. Today I'm going to be presenting our recent publication titled Ethical Considerations for the Translational Application and Review of Biomedical Research Involving AI of Hippalgaonkar. And this document is for researchers and research community hierarchies in Singapore who are interested in new perspectives on handling ethical issues in the local context. I did not write this document alone. I had the fortune to have great support from my colleagues in the center. You might recognize some of these names if you're in your fields. And we'll be covering three main topics today. The first is bias and exploring whether it is ever justifiable to implement a biased AI. Second is human involvement, or some of you might know, or I'm sure most people know, human in the loop. That's the term. How and to what extent? And lastly, the risks of risk prediction and how much risk is reasonable in an already risky world. The motivation for a lot of these issues comes from what is known as the AI chasm. So the AI chasm, it describes the gap between the development of a robust algorithm and its clinically meaningful application. Despite the promise of AI, only a small fraction of developed models are successfully implemented at the point of care. The following case studies will demonstrate ethical ways to overcome some of these challenges. So our first case is from a 2017, where a team from Duke NUS developed a deep learning system to detect the progression of diabetic retinopathy and glaucoma, referred to as DLSCR, or Deep Learning System for Diabetic Retinopathy. When a certain level of disease progression is reached, the algorithm flags the result, and radiologists can decide whether to refer the patient to a specialist. I also didn't realize I'd be following a radiologist with this. I'm sure there'll be some good questions. The algorithm was found to have bias affecting malaise. In an unbiased system, we would expect that the rates of referable diabetic retinopathy to roughly track the proportion of diabetics who are Malay, weighted by the average degree of disease control. Despite this, Malays are still referred to specialists less often than other groups. This suggests some sort of background bias. This might come from various factors such as conscious or unconscious bias on the part of physicians or graders, disparities in patient participation in screening, distrust of the medical establishment, workplace discrimination, poverty, religious fatalism, lack of education, cultural norms, and personal choice. Implementing DLSCR into this social context would likely result in more referrals to specialists across groups when compared with unaided clinical judgment. However, it could also widen the existing disparities between Malays and non-Malays. Nonetheless, if most, if not all of the causes of the disparity remained untouched by implementing DLSCR. Therefore, the question becomes utility versus equity. And we are tasked with analyzing the trade-offs of implementing DLSCR. The first part of our argument stems from the fact that social bias may be inextricable from the use of AI. Because biases occurring in a social context cannot be removed, said biases will most likely inevitably infiltrate any AI tool. Therefore, when utility and equity are at odds, we argue it is justifiable to implement the tool where, 1, its introduction reduces the influence of biases, and or 2, where the utility gain is significant enough and shared across groups. Since DLSCR would result in significant benefits in well-being as well as wider social benefits, such as prevention of job loss and disability, the implementation of DLSCR, we argue, is justifiable. Second is the issue of human involvement, or understanding how and when to keep humans in the loop and where we might think it's ethically justifiable to remove humans from the loop. So this case study refers to the NUS Medical School's development of Spine AI, an AI model. So bear with me. Right. So Spine AI is an AI model narrowing in on an MRI scan of the spine to diagnose lumbar spinal stenosis, LSS. LSS is a potentially debilitating condition affecting many adults globally with considerable impact on livelihood. Spine AI was shown to produce significant benefits, including being more accurate and consistent, making better clinical decision-making, and improving patient outcomes, improving the accuracy of inexperienced readers, improved turnaround time, and reduced costs. Each of these metrics were also demonstrated at an impressive scale, with reporting time reduced by 70%, which could result in up to 780,000 SGD in savings a year. Spine AI also avoids many common risks we see in new health AI. First, the training data was racially heterogeneous, which would suggest it is reasonable to trust the validity of the conclusions. Secondly, the tool's transparency allows clinicians to easily check its conclusions. And there are also pre and post scan consultations with the surgeon. So the overall risk to the patient is low, and since it's just an image reading tool and LSS is not life-threatening. Therefore, the biggest ethical challenge are the implications of keeping the human out of the loop. In this case, this would be removing radiologists from the automating and reading measuring of images. As mentioned, they would still be involved in the pre and post scan. As many of you know, keeping humans in the loop has often been equated with good ethical practice, and often it is. However, we should be careful to evaluate this norm on a case-by-case situation. So we argue that it is ethically justifiable to kick humans out of the loop when the technology is effective or better than a human at a given task. The risk to patients is low in the event of an error, and the well-being that is gained by the speed, accuracy, and cost efficiency of automation is high. So in the case of Spine AI, taking humans out of the loop should be justified. I'm very scared because I know we've got radiologists in the room here, so I'd like to hear your thoughts after. Our third case explores the risks of risk prediction during triage in emergency departments. Pre-admission triage includes an assessment of various factors, including vital signs, mental status, and the subjective judgment of triage nurses who should be attentive to a patient's other health red flags, such as disorientation, pain, or stress. In Singapore, all emergency departments currently use the national triage system known as the Patient Acuity Category Scale, also known as PACS. I just learned there's another PACS a few minutes ago. PACS prioritizes patients on a scale of 1 to 4, with 1 being the highest priority, meaning patients require immediate attention, and 4 for non-emergency cases. Duke NUS recently developed a new interpretive AI model to profile the 30-day mortality risk at admission. This tool adopts a machine learning model to produce a new triage outcome score known as the Score for Emergency Risk Prediction, or SERP. Like PACS, SERP is a severity classification index and does not instigate or determine a care pathway. A retrospective cohort study examined emergency department admissions at SGH and showed that SERP had better prediction scores for mortality at 30 days than existing commonly applied clinical triage scores, including PACS. However, it is currently unknown whether SERP can improve outcomes in clinical practice, as further evidence is needed to validate its real-world capabilities. Although a clinical trial may be the suggested way forward, we argue that due to accumulated data from the retrospective studies, a clinical trial may not be necessary. However, risk mitigation and minimization strategies should be prioritized. The first consideration is understanding if the risk posed by AI is exceptional in this case. PACS relies heavily on clinical judgment, which has the potential to be influenced by various factors, including the level of experience of the nurse, as well as environmental factors and emotional responses. SERP as an AI model does not rely on these factors and is not influenced by certain emotional responses. And so this comparison does not introduce new exceptional risks regarding this factor. That is not to say that emotional responses cannot be incredibly helpful in certain situations, because the care and compassion of a nurse is invaluable. This is just to say that these influences do not introduce a new riskier factor. Second is the risk of technology bias, where a healthcare professional may be wary of new tech or not trust it, or automation bias, where a healthcare professional may trust a tool too much. Each form of bias can potentially lead to misusing the tool and thus manipulate prospective data. To keep the data as natural as possible, we suggest implementing SERP with a titrating approach, whereby PACS and SERP are used alongside one another until and if there is enough robust data evidencing that SERP indeed improves clinical outcomes. Then the practice can move to SERP only. And that's all I have for you today. If you'd like to learn more, please head over to our website. You can find the full document, which I've summarized today, under our working paper series. And of course, feel free to come chat with me later if you have questions. Thank you.
Okay, thank you, Dr. Alexa. A lot of controversial points that were brought up. Any response from the floor?
I will just shout.
Hi, my name is Mong from the US. To begin with, of course, we do our best to achieve or to minimize bias and achieve equality as much as we can. But we're thinking about this hypothetical scenario, assuming that we manage to develop an AI tool that goes perfectly for one ethnic group, and not so much on other ethnic groups due to data limitations and other reasons. So inevitably, you will benefit one ethnic group and give them advantage over the others. In this scenario, then should we, in the light of equity, stop using the AI tool for medicine. Especially for medicine, like drug discovery, it's not uncommon that we have new medications. They're only proven to achieve efficacy on a very targeted niche cohort of patients. But if we move on with those medications, while talking about AI, should we still follow that kind of philosophy, or there should be a different school of thinking behind it? I'm just curious as an AI scientist. Thanks.
Thank you. Well, I think there's probably a lot of overlap in the way we think about ethical situations. And I think our approach here is to try to be bottom up, so on a case by case framework. We're trying to think about things based on the circumstances of the case and not on a wider ethical framework that follow from first principles. So the idea, I suppose, is that if you can, yeah, sorry, I'm tripping up a little bit. Did that help to answer your question?
A little bit, we can check offline.
Okay.
Okay, thanks, Dr. Alexa. Maybe some of you would like to talk about during break. So now we'll have a tea break. Just a very short 10-minute break for there's some food. You can bring it inside, and then we will move to some short AI snapshots by our AI leads here, as well as the breakout group discussion, which will be majority of the next half of the workshop. Okay, let's settle down and we can get started. So just now we heard from a number of experts from the healthcare domain, really on some of the challenges faced. But we also wanted to have a few AI leads to just give quick snapshots of what they are doing. So due to time limitation, I'm sorry we cannot have all of the technical leads here to present on your excellent work. And the purpose of this workshop is not really a symposium. We actually want to, hopefully these will trigger our thoughts on what are the new transformative ideas in healthcare that we can contribute to. Okay, so yeah. Okay, so first I'm going to invite Wilson from NTU. Dr. Wilson. Oh, there you go. Okay. Yeah, share some thoughts. So we only have one or very few slides from each of the presenters.
Oh, thanks, Rosa. Actually, the messaging was that we're only allowed one slide. Yeah, so, hello, everyone. As Rosa introduced, I'm from NTU. Now, I only have one slide here, and I'm not given a lot of time to talk, actually. So I'm just going to share a little bit about my interest area, and what I think is quite pertinent. So far, I think you've heard a lot about the applications of AI and digital technologies in the medicine. I myself am trained as a mathematician and computer scientist, so I'm more interested in how to build these models. And I think while we think about how technology can benefit human health and society, I think we should also think some pertinent questions about what makes the AI pertinent and how can we engineer and design it to make it safer. So these are some of the areas that we looked into when I am building models for mental health, which is my chosen area of specialization. And there are quite a lot of different things to consider. And I think one really key factor that hasn't really been talked about today, right, is the issue of multi-modality. How do you deal, right, with complex big data, which is dirty, incomplete, and also poorly organized in some centers as well. But as you think about these things, right, and you think about its role and potential for example, for precision medicine, then you have to think about how do we exploit the models, right, in order to achieve this task. And along the ways of building these precision models, one potential way of designing it, right, would be the idea of building personalized AI or personalized models, right, to help, right, to suit individuals' use cases or individuals' trajectories better.
But as you are trying to build such things, right, while it is really nice as magic in stone, there are also some key challenges that I just wanted to list down for your consideration. I won't have time to go into all of these, but earlier, right, you heard right from I think Prof. Daniel Ting, right, also about the cost of computation, right? So the bigger the data sets, the more the parameters, right, the more unfriendly it is going to be for the environment. And certainly when you deploy the model, the more unwieldy it will be as well. So when you are thinking about how to build these models, right, one of the things you have to consider is how do you fuse, right, different modalities together. At the same time, right, you don't want, right, to build huge chunky models because a lot of them, right, will have information that kind of like overlaps with one another. So how do you try, right, to remove, right, these autocorrelations? And mind you, it can also be really dangerous, right, to not consider this because it can also easily lead towards, right, the accurate or falsely predictive models. How do you deal with missing data that's endemic to population cohorts, which is going to be a reality to consider? And how do you think about how, right, large language models and population models can actually be used to dynamically generate knowledge and draw connections in these very data space? And finally, how do you overcome biases, especially in sparse networks for rare diseases and individuals? And this would have certain implications also for issues of equity. And with that, thank you.
Next, we're going to invite Dr. Mong. Oh,
Hi, while they're setting up, I will quickly introduce myself. My name is Mong. I'm from NUS. I wear a couple of hats. I primarily associated with the School of Public Health and also a assistant director of research in our Institute of Data Science in NUS. My team currently have about 20 researchers. Maybe half of them are PhD students. The other are research fellows. And I kind of casually organize them in three teams. The first ones are a bunch of folks working on medical imaging. And one of the flagship project is called Bendermax. Actually, my first PhD student who developed an AI tool to read digital mammograms to diagnose for breast cancer. And with the help from DSC Hub and Heng and many colleagues in the room, they managed to productize and commercialize and have this company, Bendermax. So we're glad to learn from Stephen that the big companies are consolidating. We'll be very happy to be consolidated if the price is right. Okay. And the second team, a growing team, is a bunch of researchers working on reinforcement learning agents for treatment recommendations and behavior nudgings for healthy healthy SG or also the treatment planning for chronic disease. And the last project, inevitably working with large language model, is in collaboration with SDDF, also guilty as charged. Jointly, we are developing an agent to triage our patient based on the PEC system. and I hope the demo is going to work. So basically, we jointly develop a active chatbot that's going to listen to the conversation and help the call takers automatically fill out order forms and give a estimation for the triage and also the risk for our hospital cardiac arrest. I hope this is good. That was me. Because of privacy issue, I can't show an actual body. And you see the AI is live transcribing. Currently it supports 3 languages, English, Chinese, and Malay. And in filling out all the forms at the site, automatic the conversation goes on. Actually, the price has been recommended now. And the 2 objectives, one is we try to be able to triage the non-emergency one. But I think it's really becoming a policy that they will outsource this conversation to a third party when it's a non-emergency call, so that they can spend more time talking to the patient. That's our 2 minutes they cut out the mind, is it? Okay. Anyway, yeah.
Okay, the two objectives, one is on the non-emergency end. They hope to AI can help to pick up most of these patients so that, like I say, they have new policy that they will outsource this to a third party when they can spend more time consulting the patient. Because for SDF, their KPI is within 1 minute or maximum 2 minutes, they have to triage and dispatch the ambulance. And on the other end, the very severe end, I say, they hope to be able to pick up the risk for cardiac arrest even from the phone call, maybe from the pattern, how fast they speak, how long they breathe, and how clearly they can express themselves. We do have prior data that we can pick up, not everyone, but about 20% of these cases. So love to exchange more later on. Thank you. Thank you very much.
Morning. I think we need to change the battery. While that's going on, I'm going to invite Professor Anil to come and share.
Okay, great. Hi, good morning, everyone. So, sorry, the mic. Morning, everyone. So my name is Anil Bharath. I'm based at Imperial College. I'm here launching Imperial Global Singapore, which is Imperial's presence here in the Korean building to conduct lots of different research projects. The first one we're running is actually called the Encipher program, which is about, it's really about cybersecurity for connected healthcare devices. Looking at devices all the way down at the next generation of wearables and implantables, very low power encryption technologies, going up to things to do at network levels. Now, a little bit about me and why, I'm sort of put myself in the AI category. So back in the 2000s or so, I began lots of conversations with neuroscientists working on trying to build models of visual cortex, in particular primary visual cortex. So we basically talk to neuroscientists, understand structure, understand behavior in terms of spiking behavior in single and groups of neurons. We move those into mathematical models and then turn those mathematical models into algorithms that can be parallelized. This is stuff that was done in 2000. It predates AlexNet. We spun this out into a company that was then acquired about 5 years ago, essentially for commercial visual search. But lots of the ideas came from fundamental studies of neuroscience in biological systems. For the past 10 years, my students have worked on different problems in machine learning. This includes generative models, looking at time series predictions for physical systems, being able to make predictions over long periods of time, and also generation of synthetic data that could be used for various purposes in regression testing of artificial networks that are intended to interpret visual data, for example. So this sort of thing we apply mostly at the level of microscopy, and we're starting to look at generative models, synthetic data generation, for the case of things like MRI and other modalities. The key thing we want to do in that space is for rare or emerging imaging modalities. So yes, we've got lots and lots of MRI data, we've got lots and lots of ultrasound data, but there are many different contrast mechanisms that you can use within MR imaging. MR imaging is spectacularly flexible, and so if you're generating a new pulse sequence or imaging something that's slightly different, you don't necessarily have lots of data for training AI systems. So that's one of the things that we're looking to do in the next few years. And then finally, we work with clinicians, particularly cardiac MRI, to work on tools that fit into clinical workflows that can accelerate clinical workflows and reduce time spent imaging patients. Thank you very much.
Okay, next I'm going to invite Dr. Pavitra to come and share with us. Lisa.
Hi everyone, morning. I'm based at the Institute for Infocom Research at ASAR and have the pleasure actually of working with a lot of people in this room. I double hat a little bit between the AI sort of roles there and also leading some of the healthcare applications on the internet. So I will just go one slider, just to give you a flavor of some of the things we're doing at our institute in this domain. We're focused on 4 main areas of applications. On the right, neurotechnology for rehab applications, stroke rehab, and other conditions, spinal cord injury, management of cardiometabolic disease, working very closely with a number of clinicians of diabetes, heart failure, as well as cardiovascular disease conditions. Precision health, working closely with our colleagues over at the ministry and the Health Promotion Board on population health initiatives and how we can bring AI to those kinds of applications, and then home-based chronic care. So what are we doing for these applications from the AI perspective? I think my sort of list of capabilities echoes some of the challenges shared by previous speakers. So real-world data is not easy to work with in a lot of these applications. Very, very different from the kinds of data that we can download off the internet and work with for developing basic AI capabilities and algorithms. So a lot of work there in terms of addressing irregularities and noisiness in real world data. And of course, the multi-modality challenge, how do you bring together sensor data, which is now at billion scale, actually in some of our projects, imaging data, 3D, 4D, as well as, language data, which increasingly we're seeing in a lot of our applications. How do you bring them together? We also work on infrastructure enablers. So I think privacy preserving learning was highlighted as one area of interest. A lot of our projects focus on decision support systems, whether it's image-based interpretive AI or treatment optimization, or even sort of the healthcare operation-oriented interpretive system. So predicting whether someone's at a risk of dropping out from a program that is being conducted. So those are more operational questions as well. But we are very, very focused on the human AI interaction component, and that leads me to my challenge here, which I think is worth discussing more about. So we have a lot of predictive and recommendation-oriented AI systems, but the big sort of question mark when these systems hit the ground is whether they can effectively work with and convince an end user, whether that end user is a clinician, a patient, a practitioner on the ground, an allied health professional, to sort of adopt their recommendations effectively and get that buy-in going in a high stakes and very real world environment. So these present, each of the words on that actually present many different challenges, but the question is whether we can bring together those fundamental capabilities. And of course, that requires a very multidisciplinary effort, but I think there's very interesting basic AI research questions there that, would be happy to discuss. Yeah, please feel free to reach out to me.
The final presenter is Liu Yong from Asia as well.
Yeah, thank you. Good morning, my name is Liu Yong. Yeah, so together we also have Dr. Rico from IHPC Asia. So actually I didn't know, I just need one slide, so I prepared actually multiple slides, which I'll cover within 2 minutes. So basically we do many things, starting from eye, together with Siri, Daniel Ting, and also we do liver, heart, brain, and also skin with our AI solutions. So these are the papers we published together with many clinicians, including Daniel Ting and other clinicians from different healthcare clusters. And besides that, we also published a lot in the AI journals and the conferences, which help us to build a foundations for healthcare AI solutions. So in terms of real-world challenges, these are the few key points. For example, multi-modal inputs, limited annotations, also how to make sure the decision made by AI is safe, is robust, and last but not least, how to make sure AI doesn't consume too much energy from us. Yeah, so to address the challenges, we have basically challenges also means opportunities. So for example, people are developing multimodal generative AI to address the multimodal inputs, and also have a foundation models to address the limited annotation issues, and also have a different AI solutions to address the trustworthiness of AI, and also bring AI to make sure the AI model doesn't consume too much energy. So I will give some examples of what we're doing to address those challenges. For example, we use generative AI to look into the eye images. In this case, it's OCT. So we use the first few months OCT from the patient. We can generate what happens in the 12 months. After 1 year, how the OCT will look like. So this will help the clinicians to make a decision how this patient progress in terms of glaucoma. So in this case, we're adding these synthetic images together with other multimodal inputs, EMR data, age, gender, and other inputs. We're able to predict the progression of glaucoma with AUC 4.8, which give a very good guidance for patient, for doctor to treat the patient. This is another example to improve the AI trustworthiness. So, for example, when the AI is not so sure about the decision, then we can train AI to say no. So in this case, when the AI is not so sure, AI will hand over to human doctors. So in this case, we can have a better trust on the decision made by AI systems. And the last one is how to make sure the AI doesn't consume too much energy. So in this case, we look into the transformer architecture, replacing those energy consuming parts with energy efficient parts. By doing this, we're able to reduce energy consumption about 44%, which is very useful for us to reduce the energy consumption used by ChatGPT. That's all for my part. And also we are organizing this IHPC AI workshop on foundation models for healthcare in this upcoming CI conference. So please feel free to sign up. We can also have a good discussion over there. Thank you very much.
Okay, so we are going to move into our breakout groups. Let me just so hopefully all of us are already in our various groups. Okay. So this is the website that the scribes can use. I hope the scribes know who they are. If not, the people highlighted in blue are responsible for taking some notes. All right. Okay. So what we are going to be talking about for the next hour or so is really on answering the question posed for our workshop, right? So a few things. One is to really talk about what are the grand challenges. I think we've heard many different challenges from the healthcare setting this morning, and some ideas as well of grand challenges, but maybe we can as a group refine them. And I think we've tried to intentionally place all of you so that you are amongst people, hopefully, some that you are meeting for the first time. Hopefully it'll be a good cross-pollination of ideas, right? And this is really talking about after we've identified some challenges, what are some of the roles of AI? And then where is the impact going to be if we fulfill the grand challenges that we set out to tackle? So for each table, let me flash the list again. We've nominated some leads for the discussion topics, and the leads could nominate someone to present, or you could present yourself as well. All right, at the end of this. So we are going to give everybody about 45 minutes for discussion, and then lunch will be served as well. If you want to discuss more and have lunch within the group, that's also possible. So we'll come back at 12:30 for some sharing. All right, so there should be plenty of time for good discussions. Yeah, so get to know one another. Maybe the leads can start by some introductions around the group, and then go into some of the discussion questions. Yeah, so I'll flash the. Maybe we'll try to make one slide to gather all the guiding questions all together. And for those of you who are on Zoom, who are silently participating, thank you for being here. I think what we'll do is we will also share one QR code where you can also contribute some of your ideas as well. All right? Okay, so we're going to open the floor for discussions in the breakout, please. Okay, so let's start with the first table.
Yes.
，Thanks. Hello everyone. I'm Yuan Ting. Come from AUSBM department. So now I'm graduating from Yuan to show off our discussion results. So we for the first question, like what's the main challenge that's in healthcare that can be enabled by AI? So from clinical aspects, for example, AI can help with the large-scale screening to identify patients. For example, some early detection, this kind of healthcare problems, and also one major problems in healthcare may be like the intraoperative navigation. By using the preoperative informations to do like better guidance during the surgical operation. And also AI tech, we can build up some AI system or AI platform to help clinicians for like the better medical education. So this is what's currently the main challenge that AI can help to like both sides this kind of issue. And also we discussed the technical challenge, the technical aspect. So we already know that currently we have like the foundation model, but if we would like to build up like a good foundation model, we need to have a high quality data with the application. And we already know in Singapore we do not have too much data, so this is actually the main problems we need to tackle. So one potential solution maybe like we can put the data together, utilize machine learning with like a high privacy protection. And regarding the annotation and also paired with the data, maybe we can utilize some data synthesis method to do the synthesis on like real life data. So this can also enlarge the database. And the second part is, and the third part is the trustworthy issue. So how to make the AI model extendable and also trust better clinicians is also very important topic. And go to the next part. So the role of AI. So we like to incorporate the AI. So just rather than just the diagnosis part, we know that currently AI can help the perception this part. And apart from this, we like the AI to serve like a assistant tool to into the whole clinical workflow. For example, like the scheduling, like the surgical workflow optimization, and also can help the report generation. So utilize AI to automatically generate reports, and also, for example, the education, as we mentioned. This if we can like utilize the AI to build up like augmented health in the future, it can help to reduce a lot of time and effort. And the third part is the potential impact. So what's the the outcome look like by using the AI tool? So basically, we would like to utilize the AI as a system tool to help the whole workflow, as I mentioned. And definitely, we will have like a more fast and like more efficient results. For example, after we build up like the AI education system, it can largely reduce the learning curve of the surgeon or clinician, and it can also reduce the long wait of the patients to have a more augmented hospital. And it also will have some trustworthy problems we need to pay attention to. For example, the clinical expert may not trust AI, but the junior clinicians may over rely on AI tools. So like build up the trustworthy AI models would be like the main directions we need to pay attention to. And we also need to take care about the energy cost. So we already know that AI, we need to utilize a lot of computational costs. So rather than just build up the the large foundation AI models. So how to build up like efficient AI models is often. Okay, so that's all from all of you. Thank you very much. Before that, any questions? So if you have to pick one, what would you say is the main challenge that you would like to focus on? Go on.
Oh, is it question first? We didn't know that Q&A. We thought our job is done. Sorry. What was the question again? And sorry, can't orientate ourselves.
Over there. Yeah.
Okay. Sorry.
I was just asking if you had to pick one grand challenge that you think is going to have the highest impact, like what area would you say is the most pertinent? So after the discussion, so we think like the most important part is how to build up like the data, how to encounter, like how to start the data from this and so how to build out like a large scale but high quality database with enough annotation would be like the
Maybe clinically, should we invite physicians on the table to share?
I think in my opinion, we basically, yes, I mean, just like how my colleague has just mentioned that we definitely need high quality data, but at the same time, we also need something like, a large scale screening, so good quality information that allows us the AI tool to identify individuals who are at risk. And such kind of things, I think, are still somewhat developing, but it's not out there because I think proper training is actually required for these AI tools.
Table 2, right. I have to say, I think someone's been typing in our boxes. So anyway. Yeah, thanks, Adele. Okay, so and also another thing to say is that I'm really intimidated by table 3's boxes. I mean, they're filled in spectacularly. So Stephen has been great in guiding us through some of the key challenges for healthcare. So manpower issues, that's something that is a lot of countries, a lot of healthcare systems are experiencing crunches with manpower. And it's something that it really is something of a global problem. So one solution, hopefully provided by AI, is that AI can deal with, and I have to say this is Stephen Wong's phrase, AI can perhaps deal with the non-sexy components of clinical work. Filling out forms, being able to move around with nurses and junior doctors around the wards to capture interactions between, or to capture perceptions of that doctors might make about the patients would be great, because I think that was something that was previously available and used, at least within healthcare systems he was familiar with, but it's not something, a capability that currently exists. He would like to be able to use AI to help with writing of discharge summaries. At the moment, it's something that's quite difficult to do on the fly. And we know that such a capability has been described this morning as being deployed within NUHS. One question, I guess, is what's the scalability of this? And is it just for certain areas of imaging? Is it for all areas of healthcare? It would be nice to know. Okay, there are another challenge identified here was the problem caused by mistakes in report writing and form filling within clinical workflow. So the general perception is that this adds a lot to the workload, meaning that a lot of time is spent catching mistakes and correcting for errors, or simply time spent double checking form filling and reports that or errors that might have been made in reports previously collected. So ways of catching errors and inconsistencies or reducing them would be great.
Yeah.
So one solution is, for example, it's not quite related to errors, it's actually related to errors of omission within the context of imaging. So at the time that diagnostic imaging data is being collected, it would be great to have QA on the fly for whether that image is of sufficient quality, whether the scanning protocol has been adequate for the type of diagnosis, and have that when the patient is in the clinic and actually in the scanner. So being able to do QA on the fly, having an agent sitting there looking at the images as they're required would be great. So it's QA at the point of image capture. It's probably completely feasible, but again, only in very specific domains and done in a domain by domain manner. Right, there was one, right. The next challenge that has been identified is having large enough data sets that are on a regional scale rather than say on a single hospital or a cluster scale, because that allows you to better represent edge cases and rare cases that really you can only address when you've got sufficiently large quantities of data from a sufficiently broad sampling of the population. So region level databases would be great, and there are some challenges to that, which are probably ethical and legal. Okay, so the rest I think I don't recognize, so I'm going to skip. And then the final thing, or the second thing we had here was on role of AI. So how can AI be leveraged to address these gaps? So an AI-based tool, so I guess the previous three solutions fall into that category. But additionally, what has been suggested is it would be great to have an AI-based tool that can summarize patient history on the fly. And a key requirement is also to keep track of patient journey for both acute events as they journey through a healthcare system, not just chronic events, and providing a summary of that journey up to and including any point up to the current time. The goal of that would be to free the time of doctors and nurses to be able to concentrate and really value add where it's best for them. And right, so using AI to improve data collection itself. So again, I don't recognize this stuff. Perhaps somebody who's left our table has dropped this in. Using synthetic data, yep. So that's a bit of a niche thing, but it's something that I do agree with. And finally, potential for impact. So the top three would be ways that you could measure the impact of AI on clinical care, which are, I guess pretty obvious. They're measurable. So reduction in length of stay in hospital or within the healthcare system, better patient outcomes, fewer drug interactions, and all three of these would directly translate into cost reductions, that could be achieved using AI. And then there are some other points here that I would guess are sort of secondary points. Okay, that's it from us. Thank you. Again, yeah.
Okay, maybe let's move on. Then we can have some discussion into it.
Where's table 3?
So some of the key challenges have already been echoed by many of the speakers today, and also table 1 and table 2. Number 1 is there's a lot of non-sexy problem statements, especially in operations and admin, that needs to be looked at more. Secondly is model performance. How do we deal with errors in AI as mentioned by table 2, for example, can clinicians accept a failure rate of about 10%? And then also who will be accountable for that error if errors arise. In terms of health economics, to address these errors, the developers can potentially work with the health economic units that are available within the hospital clusters to study and assess the impact of your AI solutions. Another key problem is that grant officers usually look for impactful and well outcomes. So these non-sexy problem statements may not be so attractive for the grant officers. A third problem is last mile commercialization and adoption. How can we get these solutions to the doorsteps of the clinicians and the users? Which champions or stakeholders do we engage and get buy-in from? And then how can we generate evidence before clinicians are able to adopt them into their standard of care? Another key question is, what is the cost and who is actually paying for it? Lastly, a question is workflow. How will it actually look like in the entire end-to-end clinical workflow for the clinicians, or the patients, or the nurses? Very lastly, a challenge that we talked about is data integration. It has been spoken about multiple times throughout today. The data sets within the hospital clusters are usually quite siloed, and it limits the possibility to connect them and further analyze them. Moving on to the second slide. So this doesn't actually answer the question, because we think that before the AI is actually developed, or we even think about the AI solution, we actually need to think about the different stakeholders that we need to get buy-in from. So this includes the item owners who will actually pay for the solution, who actually owns the budget. Again, bringing up health economics, what is the benefit of the solution and how will it outweigh the costs? Because usually clinicians and even public sectors and even companies will only think about the solution when the benefits outweigh the costs. And then lastly, for the public sector, in terms of funding, can we focus most of the funding towards commercialization and adoption so that we can get more returns, and these returns could potentially be pumped back into upstream research. Lastly, potential for impact, I think it has been mentioned multiple times. It boils down to cost, quality, and access. But there are two more potential impact that we thought about. The first is potentially the amount of quality AI tools or solutions that could be translated into the clinical setting. And then lastly, new ways to train both young and senior clinicians. For the young clinicians, maybe perhaps a new way is for them to spot check whether the AI has made any errors. For the senior clinicians, we've heard feedback that mostly when the young interns go to the clinical setting, they're not actually able to work well with the clinicians because these clinicians are not familiar with AI. Yeah. So moving on to the next or any questions.
No question, just a comment about the commercialization. I think that's great that you identify that. Commercialization probably needs to be on a regional scale, not necessarily just a national or local scale. Right? Cost effectively.
Next is population table 1. That's not table.
Anybody wants to go for it? I can show you what. Okay.
Yeah, so as you can see, right, no one has typed the now box, and what we've done, right, is that we've actually just used the whiteboard. This will have as well. So I think a lot of points have already been raised by the group, so I just see how I can summarize this. Right, so our theme is on pressing challenges in healthcare and image, with a particular focus on population health. So our group has discussed, and we think the following could be potential pressing challenges. The first is on the role and the utility of AI in effective individual personalized care. This is of course a no-brainer to talk about a lot. Of course, with new technologies, especially with the capability to deal with multi-modal data sets, big data, and touch through very deep longitudinal analysis, perhaps AI could play a very important role in
transforming this area towards personalized individual care and so on and so forth. But before that can even be realized, the infrastructure of data and interoperability of data is also a very crucial area and very crucial challenge right, to tackle. I don't know if anyone here has heard of the Zoom taxonomy for digital transformation, but in this 4-tier pyramid, right at the top, right, is the algorithm, right, and then 1 tier down is the digital solutions and technology. 1 layer down, right, basically will be the data infrastructure and then 1 layer below is digital literacy. So as you know, right, if we are talking about the AI, we're talking about the pinnacle of the digital transformation pyramid. But below that, right, there's a lot of different issues. But I think one thing that has been talked about a lot today, right, is whether the data is available, what can we do with it, We have to also be quite wary, when we are trying to build these models, right, we're dealing with high modalities. There's always, right, potential for information or data overload. You don't want to build models, right, that ultimately cannot be deployed in the real setting. So considering, right, the balance between, building really top-heavy models versus, right, streamlining the models, right, will be a very key part, right, towards model deployment. And so this brings us to the third point, right, which is on operationalization and implementation. So right now, I think radiology is a great use case, and many other clinical domains are also following suit rapidly as well. Other areas would be the area of mental health, as we heard earlier, and also in the area of gastroenterology, but also image forensic as well. So trying to bring these technologies, and trying to bring them, towards implementation will require engagement between not just the clinicians and the developers, but also the user perspectives, and and also ensuring that the patients themselves are comfortable with these user deployments. I mean, utility and equity is all great and well, but human emotions, right, and trust and acceptance, right, is not necessarily predicated on just these 2 dimensions. So we were also told to what was the next question? Some moonshots areas, right, to consider. Okay, so the first thing we wanted to propose is not a novel or big AI, right? That's coming up later. But I think one thing that we really need to bring to the ground is with all these developments of AI, and all these use cases, right? Are we doing enough, right, to communicate this with the key stakeholders? It's now being said or communicated with, for example, the policymakers, the insurers, and other, or even the lawyers, for example, right? So trying to understand and communicate in an interdisciplinary way, to effect communication, engagement, and even to explain, our reasoning, and of course with mutual empathy to each other's disciplines, would be really important, because without all these efforts, I don't think the AI would necessarily be very effective. Now, on the theme of a sorry, is this still on something? Moonshots, yeah. Still moonshots. Okay. On the moonshot, we're looking at the development of digital twin. Now, this in itself is not entirely a novel idea, but one thing that's very important to consider about the digital twin is actually what constitutes it. Yeah, is it about just using a very limited mechanistic model, perhaps based on molecular information or systems biology models, to build something? We think it can be a lot more than that. We are thinking that there is a very big gap in terms of the EHRs and electronic health records and electronic medical records that's already present. But I think more pertinent is the potential to stretch the utility of these data sources. So one potential idea is to say, instead of just building a standard digital twin based on existing data, when we think about the cohorts and enrollments, that goes into building these digital twins, can we convince participants to not only commit their past electronic medical records into it, but also what is present, and also commit the future as well. Because this means that we will be able to validate the outcomes and predictions of the digital twin and see whether it matches the trajectory as well.
So can we go to outcomes and impact? Right. So for outcomes and impact, I think this has already been mentioned. Quality time, the time savings, right, would be one very important outcome when it comes to the deployment of AI. I mean, everybody has been talking about time saving, and then you can focus time on improving the quality of care and all that. Only thing is that if reality is only acts like this, right? I mean, usually when you have extra time, right, somebody else, right, will think about how to use it for you. All right. So another potential impact, right, is on proactive and preventive care. Certainly, if we are able to execute the digital twin correctly and validate it, right, with what actually happens in real life, then more indications and more preventive care measures, right, can also be proposed. And I think this would be very transformative, right, in our healthcare system. With the availability of data and models, right, this also means, right, individuals like you and me can take more active charge of our own lives. Already if you are a user, right, of the Healthy SG or the healthcare apps, right, you know that your own health information is actually encoded in that. But if you couple it, right, with the model, then you can actually inquire, right, and find out some potential things that you might be liable for or you might develop in the future, and you can seek active care for, before anyone tells you to, for example. And finally, the potential for human AI synergies as well, right? So if the doctors, right, will be using the AI, okay, they will not be necessarily the only user as well. Patients, public users, right, can also engage, and I think this can give way to a very rich interaction, right, between the different sectors. So how can AI be leveraged? So these are the following things that we think are doable. I think one area, right, is on the AI-based prioritization of modalities. So the AI itself is not necessarily just used for prediction only. It can also be used, right, as a meta platform where you can actually think about what's important, and you can use that to reason about the associations and relationships across data. It can be used, right, for simulations of patients and the trajectories of their health. This, right, through the digital twin, and this can be used for forecasting. Communication and engagement, if we use and develop the chatbots correctly, then they can also be used, right, both as a front end, right, for communicating with both healthcare providers but also the patients. And finally, privacy protection, which is a really important use case because, right, to validate many of these AIs, we need to transfer potential information across different institutions and countries. And this can be legally very challenging, but some technological developments do cater and allow for this form of exchange. All right, so and that's pretty much it. Thank you.
Okay, so table 2. Question 1 on population precision health management. Identifying grand challenges and opportunities. So data quantity and quality are challenges for current approaches to, I would say, building diagnostic models for healthcare management models. So holistic picture.
Population health.
What's population health? Yeah, go ahead. Sorry, I thought I was doing that.
Okay, so I'll represent my paper. Prof Tan has left, so I'll just go through what we talked about. There's quite a lot of lines on the table, but maybe I'll just highlight some of the main ones that we focus our discussion on. Some of it not too relevant. Okay, so a lot of our discussion focus about data, how we get the data, how we use the data, and to benefit which people. Partly is it the clinicians, partly is it the patients. So the data right now, the main challenge that we have is that the data is very constrained. The data comes from everywhere. They are poor quality, poorly structured. So how we are able to focus all these efforts to combine data, not to keep them in different silos, but to combine everything. Partly the data is in different systems, health systems, partly in different health institutions, like health, and how we can work better together. to combine all our data so that we have a good set of data to help the AI building and everything else. Yeah. Part of the data, we don't want to just focus on clinical data in EMRs. Because we're focusing on population health, a lot of patient data actually comes from wearables. So in our group, there are a lot of people working on wearables as well. So how we don't want to just get data every 6 months that the patient sees the doctor. So how do we implement all these other data that they get from all these other wearables and daily activities into the data of the patient so that we can get a more complete picture of their health, to understand what's affecting their health, how to benefit their health more. Yeah. How do we? The main problem with this is, of course, interoperability. There are a lot of different platforms, different systems. We find data in so many different places. How do we get all the data into one place for the clinician to use, or the patient to use, instead of opening 10 different windows, 10 different apps to find all their information? Next, we also, some of the challenges is how we end up using the AI in the real world. So a lot of it is only applicable to the training set, or if you have any approval from the HISA, it's only for certain equipment or for certain algorithms. So we might not be able to use it to the whole population. So how do we, so in the end, it comes back to the data, having a big enough data set that's suitable for the population and we use it. Yeah. One of the main challenges that we're talking about was also about data cleaning. So a lot of time we spend on getting the data is on cleaning. 80% of time on this AI project is actually data cleaning. So there's a lot of poor quality missing data. So how we can use AI to actually help us with this to improve the collection and speed this process up. Yeah. Okay, so maybe the next question would be the role of the AI. So what we talked about, so we do want to, so like partly it's also moonshot ideas, how we want to build foundation models, so based on the data that we have, based on the entire population, so that you apply to the Singapore context, and in future when we implement them, we don't need as much data to implement and test and use all these models, yeah, and algorithms that we have. The role of AI, actually, we look at it more as a tool to empower the patients. So to give the patients more responsibility for their own health, to give them the knowledge for their own health, so how they can use it better, so they can take charge of their health as well. Then the last point, talking about the potential for the impact. So we don't want AI to end up us interacting with machines more. We actually want to use the AI to increase human-to-human interaction, actually, so that the AI saves us time. In the training encounter, we are able to spend more time with the patients, explain to them, to help them better with their care. And we want to make sure that the care is more as a shared decision-making kind of process, rather than the clinician explaining the patient what to do. It's more a shared process where the patient takes charge of his own health. The patient knows, based on data and other things, how to help themselves better to manage their condition. Thank you.
Okay, so our table is on remote care and coordination. So I think we came up with, we spent a lot of time on the first question, but I guess I'll just try to summarize. So I think remote care is quite clearly driven by the crunch in manpower. Right? So everything that is in the acute setting is getting pushed to maybe primary care and to community setting. So that is a general direction, I think, is definitely going that way by hook or by crook. And a lot of our discussion is how could AI play a bigger role in this space. So a few things that we were talking about. First is in terms of sensing technology, right? For the doctor to not directly detect the patients, what are the new sensor technology that could be developed, or using existing computer vision type of technology for creating new ways to detect digital biomarkers. The second one is on digital therapeutics. I think we spent some time to discuss what are the new ways that therapy could be given to the patients remotely, right? And the acceptability of that. And the last part that we were talking about is in terms of coordination, because for one patient now there could be many different doctors, nurses, other kind of therapists that is taking care of this one person. So in terms of coordination between all these different healthcare workers, what could AI do for that? So let's go to the role in AI. Okay, so for how AI could play a part, the first idea that we had is that it could potentially help to speed up the pathway, and we did discuss that for the pathway for the research to really have impact. A lot of it could be policy and all of this, but in terms of just based on research, are there ways that we can perhaps think of using AI to shorten some of the developmental steps, the discovery of the new biomarkers, or even in terms of clinical trial, there be ways to have shorter clinical trials or even skip some of the proof of concept stages that will allow the deployment pathway to go faster. The second is that there will be this evolution of clinical practice, right? We'll talk about how radiology, the whole field of that is born because there are new modalities of imaging. So in this sense, because we have to move towards remote care because of our Asian society and all that, the clinical practice will evolve with the development of technology. But how could we use AI to support this asynchronous telehealth support? Yeah. I think the last 2 points is really talking about that one of the key challenge that clinicians and nurses, right, they face is that with AI and a lot of this continuous monitoring and remote monitoring, that there could be a lot of noise, a lot of red flags that are serviced to them, but they might not be real. So how to really be able to detect the correct signals? I think this is still a big challenge that perhaps AI can do. So, okay. Yeah, so I think this one is very similar to all the other group sharing in terms of reducing the burden of the actual healthcare staff. In terms of intervention, how do we get digital interventions more quickly used or being accepted for use, and modalities such as computer vision would provide new ways of detecting and sensing the changes. Okay, so yeah, that's public.
I'm asked to say some words before we end off. Right? So thank you everyone for coming. So I think, as you can see today, the healthcare landscape is very complex. Right? No one entity or no one team can actually solve all the problems. So I think today is more of a start of a conversation. So you have gotten to know many people across the whole clinical system, right? So across the different classes. So I think it is good opportunity to get hold of their name cards or their LinkedIn, WhatsApp, to continue the conversation in preparation to respond to AI for science grand challenge. Right? So I think today is more of a very high level of opportunities. So I strongly suggest, at least within your table, right, of a common interest, to get your contact and to have follow-on meetings in preparation for this run call. But in order to summarize some of these things that I've heard about today. So, okay, my team, a bit more about myself. My name is Rick. I'm from A*STAR. So my team has been working in AI for population health and digital health for the past 8 years. it's not easy, right? So we have been working with clinicians to sign project agreements, to get all the data, to do AI. Then the challenge, another challenge emerged, right? Like how are we going to deploy this? As what Robert Morris mentioned, if there's no intervention, if at the end of the pumpkin Cinderella story, right? If after the end of a say $5 million grant, there's no intervention, then how successful are we to say that we have published some nice papers? So certainly there's a huge gap from research to translation, right? Which brings about to today's conversation on having an infrastructure as a start, right? And then using this platform, this infrastructure to collect information, to collect data, right? So Ian talked about silo, right? Even within a health cluster, there are silos. Right? Many clinicians hold on to their data because we all understand that these are assets, these are gold, right? In today's context, especially with AI and GPUs and all that. So, collating information and then doing the AI, then translation, then how can we accelerate the development of AI to translation? And then some of us may aspire to have startups, spin-offs, right? So then that takes another set of expertise, right? To really find CEO, to get grants and all that. Maybe then that could be the real value capture of not just within the health cluster, but to scale up to national level and then bringing this overseas to international markets. And then this, I believe, would be a better position for Singapore to do value capture. Grand challenges. So AI for science, grand challenge. We certainly need to think of the AI grand challenges. For example, when we collect data from specific hardware equipment, right? Does it work when we train this? Does it work when we roll it out to other types of hardware? Probably not as good accuracy as we want, right? Sensitivity and specificity. So then how can we manage this, right? Domain adaptation, generalization, and all the AI folks can come in to mitigate the gaps. Foundation models. So a lot of the teams here, either you're doing pre-training or you do continuous training. That means you pre-train the model already, where you take some public open source data models, and then you continue to train it using additional domain-specific data sets, then to enhance the accuracy of the AI models. So then maybe that would be a better way of, say, training from scratch. We talk about clinical unmet needs, right? So today there's radiology, there's cardiology, there's ophthalmology. So in every domain, there are opportunities to solve, right? So that is really up to the teams to find out what are the most pressing needs, what are the real or the most important clinical unmet needs, right? Who are the clinicians involved? And then we can pull together the various AI scientists, researchers to help to solve these issues. Thereafter is also to talk about people who are not in this room, right? The radiographers, the nurses, because they spend a lot of time in admin work or in processing all this information ready for you to do your AI. So how can AI actually help them to reduce the time needed to do all of this, so that then they have time to do patient interaction and all that. But having said that, the proposal, I believe, should not just be on making process optimization. I think every proposal will still need elements of advanced AI. Then adoption, right? After we develop it, we try to roll things out. What about the adoption? So for population health, maybe it's like through some apps, right? That you want to say digital therapeutics. You want to help the patient, diabetic patients, to improve their condition, right? How can we encourage them to exercise? That takes another expertise, right? Through nudging, behavioral science. So all this probably will need to include a very diverse team put together to not just solve the clinical unmet needs, publish excellent papers, and then adoption, and then roll out, and then national level. Okay, so we often talk about health care. So patients are already sick. I think we may also want to delve a bit into patients who are still healthy, and we want to continue to keep them to be healthy, right? Increase the number of years that they're healthy. So then we talk about maybe community screening, right? Which is aligned to Healthcare SG. So we also may need to consider what is Singapore's some of the initiatives or programs. So community screening is one of them. And because we want regular screening, so it should be low cost, non-invasive, right? So then maybe AI will come in to develop some new tech that can help the government to save money, right? So it's all our taxpayers, it's our money, right? We are contributing to income tax. So how can we, by contributing this income tax, really get the best return of investment from what we are paying the government for? Then this also aligned to the 40, 30, 20, 10 rule that Robert mentioned a while back. That is a framework to emphasize the different factors that contribute to a person's health span, right? So lifestyle behavior, 40%, right? Contributes a lot to your current health condition, your current health state, versus say healthcare about 10%, right? Then of course in between is all your genetic factors which you can't really change much, right? So lifestyle, behavioral is probably another key area to look into. So I hope today you have taken away something, and I believe it's just a start for your journey in AI for digital health and population health. With that, I thank you.
Okay, with that, I think we are come to a close for the workshop. So yeah, thanks, Rick. I think we all here understand how it's such a long journey, right, to get something in healthcare really show impact. But hopefully all of us have made some new friends here. I was just talking to someone that, you know, how do we have good clinical collaboration, right, for the scientists among us. And it's really about the relationships that we build and how we can really work together for extended periods of time to see real results now. So I wish you all very pleasant afternoon after this. I hope to gather all your inputs, and as a team, myself, Rick, Daniel, Cher, Heng, yeah, we'll try to draft something and hope to influence NRF in some of the future phone calls. Yeah. So thank you all.